The first question, the 64-year-old diabetic man developed an infected foot ulcer. Which of the following is most likely cause of the infection for the diabetic foot? Is B.
Yeah, Staphylococcus aureus is the commonest organism recovered from infected diabetic foot. If they ask you what's the first line antibiotic therapy to give in this case?
That's the fluoxetine.
Yeah, excellent. Okay, both of these were questions in the exam. Diabetic foot, very important. They can ask you what's the pathophysiology. They can ask you what is the that is treatment of choice. They can ask you organism. Okay, so please revise that topic from the notes. Okay, let's see the next one.
Which of the following pathological changes is seen in the pulmonary tuberculosis? Is it gone focus? There is the gone focus. There is creating granuloma, but the first scene.
First,
Giant cell of the macrophages. The first macrophages, the giant cell. I didn't get it. I think is it A? Epithelial cells in the macrophages. Because I'm confused in the gone foci and this one.
I can see the confusion, no problem. Do you guys want to discuss the sequence of events in TB?
Yes.
Okay, let's discuss the sequence of events in TB. So TB usually, it's acid fast, right? Bacilli. Usually Mycobacterium tuberculosis hominis. That's the organism usually causing it. And most of the times you inhale it. Sometimes you digest it, sometimes it's inoculated, but in most of the cases you inhale it, right? You inhale the tubercle bacilli. Okay, when you inhale the tubercle bacilli reaches the lung tissue, right? Usually in the right lung, and it seats there, usually subpleurally. That is just under the pleura. These are the tubercle bacilli arriving here. Okay, the first cell which will encounter these tubercle bacilli is macrophages. So macrophages will come and that's our macrophage, and it will engulf these tubercle bacilli. Tubercle bacilli are internalized, right? Internalized into a vesicle, right? This vesicle is called endosome, and it should fuse with a lysosome, right? So lysosome is here. Lysosome contain dangerous enzymes and things like that, and they should fuse together. These two vesicles should fuse together. But the TB bacilli is very smart. It will prevent that fusion. That was a question in the exam, right? How does tubercle bacilli evade destruction by macrophages or the immune response? It just simply, it's engulfed just fine, but once inside, the cell does not kill it. It cannot kill it because you cannot fuse the lysosome with the endosome and thus kill the bacteria. So tubercle bacilli keeps multiplying intracellularly, okay, inside of the macrophage. Macrophage will produce certain cytokines, right? And these cytokines recruit more macrophages. More and more macrophages come to the scene. These macrophages are activated macrophages. Okay, these macrophages are activated macrophages, and they are densely packed with one another, resembling epithelial tissue. When they are packed densely with one another, they resemble epithelial tissue. So they call it epithelioid cell. These are the first changes, pathological changes that happens. Formation of an aggregate, localized aggregate of epithelioid cell. So in the big picture, you will find like a tubercle, right? With many densely packed macrophages. These called epithelioid cell. And the center is not necrotic yet. In the beginning, it's not necrotic. Some of these macrophages that are densely packed with one another, they just simply fuse with one another, forming giant cell, right? So giant cell is not seen at the get-go, they are seen later. When the epithelioid cell come together, densely packed, then giant cell starts appearing within the tubercle. The center of the tubercle also become necrotic in the end, forming a caseating granuloma. So this change in primary TB, we call it Ghon's focus. Once the pathological process is established up to this point, we call it Ghon's focus, right? So Ghon's focus is just what? Caseating granulomas, usually located in the right lung, usually subpleurally, and that's it. It's a feature of primary TB, okay? Then the draining, so suppose you have this part of the lung here, suppose right lung, subpleurally, there is tubercular situation going on here. The draining lymphatic vessels also become seeded with tubercles. Okay? The area bearing the tubercles, when they are drained, these lymphatics also get affected. This is called tuberculous lymphangitis. Of course, they drain to the pulmonary hilar nodes, which also become infected and inflamed and enlarged. This is called tuberculous lymphadenitis. So as a whole, Ghon's focus, tuberculous lymphangitis, and tuberculous lymphadenitis as a whole, as a group, they are called Ghon's complex. Okay? Then, if the person have very good immunity, this will become, resolved. Right? The situation will resolve and become calcified. Right? And this calcification, dystrophic calcification, which happens in the tubercles, is referred to as Rathke's complex. Rathke is called Rathke's complex. Okay? So it means, for this question, they want the earliest change which is seen right after you inhale the tubercle bacilli is the appearance of epithelioid cell, which are derivative of activated macrophages. Okay, let's see the next question.
All right. 40-year-old man is trapped in the house fire, and he's presented with a circumferential burn in both upper and lower limb, I think, and there is no pulse felt on the left side. What you will do? So circumferential burn is there. So either fasciotomy, either ischiotomy, but I will say C, ischiotomy.
Yeah. So it's one of the local complications of burns, right?
Yep.
Ischiotomy is just incision through the burnt area. That's it. Fasciotomy is like different, right?
I want to ask if there will be the injury or like a history of the pain, then we can go for with the fasciotomy also, right? Like the pain and the passiflexion and this all.
There will be these symptoms will be there. These symptoms will be there. Yeah, this is compartment syndrome, but it's like slightly different than that. It's like a tourniquet, right? When the skin is burnt, it contracts right away and forms a tourniquet-like effect around limbs or even around the trunk. It can happen in the chest as well, or abdomen. But anyway, the cause is not inside of the confined compartments. The cause is not edema of the muscles inside of the compartment. The cause is extrinsic compression, it's like extrinsic compression. So the treatment of choice will be ischiotomy to release this tourniquet. Right? It's not fasciotomy. It is not fasciotomy. It's ischiotomy. Agree?
Yes.
Good, very nice. Let's see the next question.
Which of the following is a long-standing, that is a chronic complication of the diabetes mellitus? It is orthostatic hypotension, decay, hypersmolar, hypoglycemic state, hypoglycemia, and they're asking the long-standing complication of DM, diabetes mellitus.
Yes.
Is cellulitis? No. Orthostatic hypotension, I would say. Is C or E here? And then
They want something chronic complication
the chronic complication they're asking, right?
of diabetes, chronic complication. So what are the chronic complications of diabetes? Like, for example, coronary heart disease.
Yeah.
That's chronic, right? Okay.
Diabetic
Like,
neuropathy.
Yeah. Yes. Diabetic nephropathy, diabetic neuropathy, diabetic vasculopathy.
Diabetic
Okay.
ulcers, food disease here.
Yes, ulcers, like peripheral vascular disease also. Okay, those are all chronic. Acute, like infections, all right? It's acute. Like, for example, someone who have DKA, that's acute. Hypoglycemia, that's acute.
That's acute,
Hyperosmolar, that hyperosmolar hypoglycemic state is more in type 2 diabetics, but whatever, it's also acute, okay, not chronic complication. So it means orthostatic hypotension happens because of what in diabetes? When diabetic person stand up, they faint and their blood pressure drops. Yes, Suleika, thank you very much. That is due to autonomic neuropathy. Is that right? Autonomic neuropathy. Because we know that when you stand up, your vessels should constrict. Your vessels should constrict because the baroreceptor reflex is activated. Those reflexes are mediated by autonomic nervous system, right? If your autonomic nervous system is not working correctly, it means this function will be lost. When you stand up, your vessels don't constrict. So your blood pulls to the periphery and you faint, right? Okay, let's see the next one.
The patient is found to have the Meckel's diverticulum, which of the following embryological, that's a vitellar intestinal duct. And we can specifically say the proximal part of the vitellar intestinal duct.
Yes, very excellent. Vitellar intestinal duct. We don't have to explain that. Let's see the next one.
Yeah. Which of the following is the correct statement regarding the spinal accessory nerve in the posterior triangle of the neck? It's a posterior triangle of the neck and here border of the lower of the sternocleidomastoid, anterior border. Is it A?
A. Okay. Anyone else agree? Okay. C.
Upper half. Because it supplies the two things, like the trapezius and the sternocleidomastoid.
Yeah. Okay. Let's talk a little bit. Okay.
Yeah.
How to do that? Yes, like this. Okay. And like this. All right. I'm gonna draw some landmarks. Okay. First landmark is the mastoid process. That's mastoid. Imagine that this is the mastoid process. And this is clavicle. And manubrium here. Okay. And we know that sternocleidomastoid come from here and insert here, right? That's sternocleidomastoid muscle. Okay. And this is trapezius. Is that right? Trapezius is like this. And this is posterior triangle, right? Posterior triangle is behind sternocleidomastoid, in front trapezius, above middle third clavicle, right? Okay. So, you know cervical plexus? Cervical plexus. It has several sensory nerves, right? Anyone can tell me what are the sensory cutaneous branches of cervical plexus? What are those sensory branches of cervical plexus? Zuleika, transverse cervical nerve. Yes, that is correct. Greater auricular nerve. Correct. Correct. Lesser occipital nerve. Very nice anatomy background, Zuleika. Very good job. And suprascapular nerves. The suprascapular nerves, right? So all of these nerves, they emerge here, at this point. Transverse cervical moves like this. Suprascapular moves like this. Greater auricular move like this, and you know. So all of them come out here at this point, which is where? Which is midway along the posterior border of sternocleidomastoid, midway. This point is called Erb's point. This is called Erb's point. Erb's point, or called punctum nervosum, whatever you like, okay? Punctum nervosum. Okay, spinal accessory nerve exit the skull. How? How does it exit the skull? With which foramen?
That's the main foramen, like the foramen magnum.
No, it enters skull foramen magnum, then it exits again through what? Jugular foramen.
Jugular foramen, okay.
So here it is. That's jugular foramen. Imagine with me. And here it is coming out. So initially, at the very proximal part, post-foraminal part of accessory nerve is within the carotid sheath. But it doesn't stay there for long. It immediately exits carotid sheath and moves backwards, deep to sternocleidomastoid. Here it's moving deep to sternocleidomastoid. Here it will supply it on the way, and then it keeps moving, and comes to the posterior triangle at this point, which is roughly 2 centimeters above Erb's point, roughly, or 2 finger breadth above Erb's point, or punctum nervosum, which is along the junction of upper third and middle third of sternocleidomastoid. So here, right? Suppose that's upper third, this is middle third, and this is lower third, right? It comes out here, junction of upper and middle thirds, 2 cm above punctum nervosum. And then now it is in the posterior triangle of the neck, deep to the prevertebral fascia. It will move deep to the prevertebral fascia, moving down, and disappear again under trapezius and supply trapezius. It enters trapezius approximately at the junction of lower and middle thirds of the anterior border of trapezius. So suppose this is upper third, this is middle third, this is lower third. So here, which is junction again of middle and lower thirds of what? Anterior border trapezius. So they want us, what is the correct anatomical relation of spinal accessory nerve in the posterior triangle here, in this triangle? What is the correct? So answer is either posterior border, upper half sternocleidomastoid, or anterior border, lower half trapezius. Is that right? Either this or this. Do you agree? Yes. Okay, so let's see the question. So we agree now. We agree. Let's see the question now. Let's see it again. Which of the following is correct statement regarding spinal accessory in posterior triangle? Okay. Option A, posterior border, lower half, sternomastoid. Yes or no? No, right? That's no. Because we agreed upper half. We agreed. Okay, anterior border, upper half sternomastoid. We agreed posterior border now. We're talking posterior triangle, so no. Then C, posterior border, upper half Sternomastoid. Yes. Okay. So it is C, right? Simple. Life is very simple. Let's see the next one.
The following a thoracoscopic sympathectomy, a 39-year-old patient complains of meiosis and ptosis. Which of the following other manifestation is seen in the case? Like this is a Horner syndrome, right? Like, and we are going to remove it. So that's anhydrosis, ptosis, meiosis, anhydrosis, and anathermosis. What is other features, manifestation? Is C, like anhydrosis is there? Yeah.
Yeah. Yes. Anhydrosis is there. Enophthalmos is there, but they call it like apparent enophthalmos. It's not really enophthalmos, okay? Because the eyelid droopy a little bit, you feel like the eye is sunken, but it is not really sunken,
Okay.
right? Okay. So it's not true enophthalmos. So answer is C. Okay, easy. Let's see the next one.
A patient present with the enlargement of the superficial inguinal lymph node. On examination revealed no lesion in the scrotum or penis. Which of the following site of the pathology? So it's D, anal canal, right? Superficial inguinal lymph node.
Okay, I agree with you. Right? Because anal canal drains there. So I agree with you. Yeah. Good. Okay, let's see the next one.
Can you tell me about the glands penis? It is deep inguinal, right? The glands penis.
Yes, it's deep inguinal.
And the upper vagina is also the same? Or
No, upper vagina is not deep inguinal. It's internal iliac lymph nodes.
So yeah, okay. That's what.
Okay. All right.
Yep. Which of the following best describe the lesser splanchnic nerve? Lesser splanchnic nerve. Splanchnic is it's E or C.
That's more options. Oh, what did I do?
Yeah.
Yes. Okay.
I think it's a pre-ganglionic sympathetic or post-ganglionic sympathetic.
So
I think it's
like
post.
every combination. In the options, they just made like every possible combination. Pre and post sympathetic. Pre and post parasympathetic. Whatever. Okay, so,
is it A?
Post ganglionic sympathetic.
Oh,
okay.
It's pre. Let's see.
Muhammad said C, which is pre-ganglionic sympathetic. Okay. Do you want to discuss that, or do you know it, guys? Do you want to discuss those splanchnic nerves? There's the lecture in the website, but I will summarize. Okay, the lecture is like 1.5 hours long, talking in detail about splanchnic nerves, but I will give you the points that you want in your upcoming exam. Okay, just the specific points. Okay, so I'll be simple. I'll be the simplest possible. You know that's spinal cord, okay? That's spinal cord. That's spinal cord. And you must be knowing that if you take section in the spinal cord, anywhere from T1 to L2, you will see lateral horns. Is that right? But if you take section above T1 or below L2, you will not see lateral horn. Right? So here, basic structure spinal cord have 2 ventral horns, 2 dorsal horns. But if you take section from T1 to L2, there will be lateral horn, which is intermediolateral horn. Some people like to make it more annoying. Intermediolateral horn, or simply, let's say, lateral horn, okay? These lateral horns, they contain cell bodies of sympathetic, preganglionic neuron. Okay, so suppose I take section spinal cord. Those are all like segments in the spinal cord, starting from T5. Okay, so that's T5 section. And then you have 6, 7, 8, 9, 10, 11, and 12. Okay, now normally what should happen? Normally, of course, what's on the sides of the spinal column? Sympathetic ganglia, is that right? Those are our beloved, lovely sympathetic ganglia. Okay, sympathetic ganglia contain the cell bodies of postganglionic neuron. Okay. Now, splanchnic nerves. What's the meaning of splanchnic? Splanchnic, the word splanchnic in Greek means something inside, viscera. Viscera, right? Like stomach, small bowel, heart, lungs, anything contained in your body cavity is called splanchnic, viscera. So when you say splanchnic nerve, you mean it's a nerve that supplies viscera. Is that right? Okay, so from T5, T6, 7, 8, 9, 10, right? All of these come together. They come together. First of all, before they come together, actually, they just enter the ganglia but don't synapse. Okay, they just move through the ganglia without synapsing at all. They just move like that. Okay, and then they come together. They come together in one nerve. This big nerve is called what? What's this big nerve? It's called greater splanchnic nerve. Greater is called greater splanchnic nerve. So what is greater splanchnic nerve? Preganglionic sympathetic nerves originating from T5 to T9 and sometimes T10. T10 is variable, Muhammad. In some people, they have T10 with it. In some people, no. It is variable. Okay. So they come together in a beautiful filament, and this filament is formed in the chest. This nerve is formed where? In the chest. Now it have to move where? To the tummy, to the abdomen. Okay. This is aorta, and that's bifurcation aorta. This is celiac artery. This is superior mesenteric. This is inferior mesenteric. And those are like renal arteries. Is that right? Now look, there's a very special ganglion. There's a very special ganglion located near or about the origin of celiac trunk here. It's simply called celiac ganglion. Simply, it's called celiac ganglion. The greater splanchnic nerve move like this, down, 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 and it actually penetrates the crura of the diaphragm and synapse here in the celiac ganglion with the postganglionic neuron. Then postganglionic sympathetic fibers just simply move with the branches of the celiac artery to the spleen, to the pancreas, to the liver, to the what? To the foregut, to simplify it for you, to the foregut structures. So greater splanchnic nerve is meant to do what? Sympathetic supply to foregut. Simple? Are you with me now, or did you sleep? Okay, not asleep, thank God. So, but there's just one little detail I like to add, okay? Just tiny detail. This tiny detail is that before the greater splanchnic nerve reach the celiac ganglion, before it reach, okay, it just gives one little branch here that goes to this thing, adrenal medulla. So it means adrenal medulla is supplied by preganglionic sympathetics coming from greater splanchnic. That's before, okay, that's so important detail in exam, before it synapse, okay, so it remains preganglionic throughout. That's greater splanchnic. Now, coming back to our beautiful spinal cord, another nerve come out from T10. In some people, T9 is included, and in some other people, T11 is included. So it means you can remember it T10 plus minus 1, either 9 with it or 11 with it, but T10 is always there. This nerve just simply move like this also through the ganglia without synapsing at the chain, and follow just the same path as greater splanchnic through the crura of the diaphragm, and then it comes here. It comes at a special ganglion located here, at a junction between aorta and renal artery, or some other times here near the superior mesenteric artery. So variable. It may end up in this ganglia or this ganglia. This ganglion, this one, which is between aorta and renal artery, is simply called aortico-renal ganglion. It's called what thing? Aortico-renal ganglion. And this one simply called superior mesenteric ganglion. Superior mesenteric ganglion. But anyway, the postganglionic fibers move with the branches of the superior mesenteric artery to supply midgut. So I've talked about the course of this nerve and what it supplies. What's the name of this nerve? Comes from T10, go to the foregut, supply foregut. What's the name of that nerve? Midgut. What's the name of this nerve? Thank you. Lesser splanchnic nerve. Lesser splanchnic nerve. And finally, we have a nerve which in some people it's there, some people not, but let's talk about it anyway, which comes from T12. This nerve also move without synapsing and also enter abdomen with the same pathway, but actually move like this toward the kidney and supply kidney and ureter. It snaps at a plexus here called renal plexus and supplies kidney and ureter, but not adrenal gland, okay? Adrenal gland, as I told you, greater splanchnic. This nerve is called least splanchnic, least splanchnic. So what is common in among these nerves? All of them, greater, lesser, and least, all of them are called thoracic splanchnic nerves. And all of them are, please don't forget this, pre-ganglionic sympathetic. Please don't forget that, okay? I always say that and everyone forgets it again. All of them are pre-ganglionic sympathetic nerve fibers. Clear? Now, when we come down to L1 and L2, and of course, here's our lovely sympathetic chain. From L1 and L2, some nerves come out. They are usually 2 in number, but could be 4. And these nerves, they move to the sympathetic chain and now they synapse. And from the sympathetic chain, postganglionic fibers emerge out. So that's not like thoracic splanchnic nerves. It is different. Thoracic splanchnic nerves remained preganglionic throughout their course, but these nerves, they synapsed in the sympathetic chain and emerged as postganglionic sympathetics. These are called lumbar splanchnic nerves. These are called lumbar splanchnic nerves. Lumbar splanchnic nerves. These lumbar splanchnic nerves, they come out as postganglionic, okay? They come out as postganglionic and move to the aorta and simply move along with the branches of the inferior mesenteric artery and supply most, not all, but most of the hindgut. Okay. But some of these fibers, they don't move like this. Some of these fibers move down. Down, 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 down. And I need to add a slight detail to understand the following point. So stop here, forget about that, stop here, and let me tell you something else quickly, just in 1 minute. This is aorta, and that's celiac artery, superior mesenteric, inferior mesenteric. You must be knowing that there's a plexus of autonomic nerves that surrounds the aorta, anterolateral to the aorta, right? This plexus of nerve begins just at the level of the celiac artery and move down, 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 down until below the aortic bifurcation, and then it's split into two nerve bundles. And that enters pelvis. So that's, suppose, pelvis. I will represent it like a ball. And they enter pelvis. They join some other nerves. I will not talk about them now. Okay, but it's in the lecture, don't worry. But for the purposes, I'm not going to prolong it too much. But I want you to know that all of this bundle of autonomic nerve is called prevertebral plexus. And it has subdivisions. There's a division around the celiac artery and superior mesenteric. We call it celiac plexus. And from the superior mesenteric to the bifurcation of aorta, we call it aortic plexus. And below the aortic bifurcation, we call it superior hypogastric plexus. In the pelvis, we call it inferior hypogastric plexus. So it means all of this is called prevertebral. All of that is called prevertebral plexus. But it has subsidiary plexuses, right? We call it celiac, aortic, superior hypogastric, and inferior hypogastric. Now, did you know here in this part, I want you to focus here now, this is called superior hypogastric plexus. This plexus divides into two nerve bundles. We call them, listen so carefully, very important, hypogastric nerves. Hypogastric nerves. Okay? Now let's come back to the lumbar nerves that we talked about. We stopped at this point where we said some of the lumbar splanchnic nerves move down. They move down like this, guys. They're moving down along the inferior hypogastric plexus and then along the hypogastric nerves and then to the pelvic organs. They are already postganglionic. Remember, they are already postganglionic. And they supply pelvic organs. Prostate, seminal vesicles, vagina and uterus in females, rectum, urinary bladder, all of that. Okay, even vas deferens and epididymis, all of that. And they mediate ejaculation. So it means, what is the pathway of ejaculation? It begins at L1, L2. The impulse move to the sympathetic chain and then move along the lumbar splanchnic nerves, which are postganglionic, don't forget that. And then they move through the prevertebral plexus, inferior hypogastric plexus, and then through the hypogastric nerves to the inferior hypogastric plexus, and then to the pelvic organs. So in the exam, if they tell you which of the following is damaged that lead to loss of ejaculation, if you answer lumbar splanchnic, that's correct. If you answer spinal cord injury L1, L2, that's correct. If you answer hypogastric nerve, correct. Is that right? All of that is correct because all of that is in the pathway. In the pathway. Finally, last thing, sacral splanchnic nerves. Sacral splanchnic nerves. We discussed what? Thoracic splanchnic, lumbar splanchnic. Now in the end, sacral splanchnic. It's so simple. Sacral splanchnic nerves have a very weird story. It's a strange story. This is sympathetic ganglia. We know, I will draw sacrum here. I will draw coccyx, that's coccyx. And then, you know, sacrum, it's wedge-shaped bone, 5 fused sacral vertebrae. Those are the ala of the sacrum, sacral promontory. And we know that there are 4 pairs of anterior sacral foramina and posterior sacral foramina on the back. The sympathetic ganglia chain move down like this, and they meet here. They meet in front of coccyx at a ganglia called ganglion empire. At a ganglia called ganglion empire. Now, about sacrosplanchnic. What happens, guys, is that fibers from L1 and L2, they come out. They come out, and those are preganglionic. They do not synapse at the same level. They descend, 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 come down, 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 until the sacral sympathetic ganglia. Here they synapse. And postganglionic fiber come out. They come out, and they go to 2 directions. Some go to the pelvic organs, but that's minor contribution. And some go to the lower limbs. Sympathetic supply to the lower limbs. That's all that I need you to know. Okay, so any question about that topic? So we are clear that thoracic splanchnic nerves, greater, lesser, and least, all of them are preganglionic. Lumbar and sacral are postganglionic. Okay. Let's go back. Let's go back. So it is easy now question, right? Preganglionic, sympathetic. Let's see the next one.
Okay, a 10-year-old child is brought by his parent to the ED, and the boy complains of something stuck in the throat. On plain radiograph, an object is identified at the level of T4, and the parent report there's probably a fishbone. What is the best course of action? I think that's E, endoscopic removal. It's T4.
Yes, and there's no fun in saying that. This sharp object perforation is there, can be. So we need it removed. Okay, let's see the next one.
They're saying, by which of the following mechanism does the body dissolve clots form in the context to DIC? By which of the following mechanism does the body dissolve clots? Plasma. I know some fibrin degeneration products is there, but let's go with D.
Yeah, okay, plasmin, right? Clot that is already formed is dissolved by plasmin. You know, patients that have myocardial infarction, of course, you must be hearing that they give them systemic thrombolysis. Is that right? To dissolve the clot in their coronary artery.
Yeah, exactly.
What's this injection? It's formed of what? Yes, Amar, which is tissue plasminogen activator. It's not plasmin itself, this injection. This injection is meant to activate plasminogen in our own body. In our own body. It's already there. Plasminogen is there. Okay, we don't take it from outside. It becomes plasmin. Plasmin comes and dissolves the clot. Okay, it degrades fiber. Muhammad said, why not E? Okay, why not E? Tissue factor. What's this? What's tissue factor? Oh my God. What's tissue factor, guys? You don't know that? Please tell me. Yes, Muhammad. It doesn't have anything to do with dissolving a clot, okay? It activates the extrinsic pathway of coagulation, factor 7. So it doesn't have anything to do with dissolving an already formed clot. Okay, let's see the next one.
Which of the following cervical vertebrae do not have the bifid spinous process? And that's C7. It doesn't have the bifid spinous process.
Okay, good.
30-year-old man is involved in the RDA and sustained a cervical spine injury. The imaging shows a fracture of the transverse process of the C7 cervical vertebrae. Which of the following is most likely to be injured? There is transverse process of the C7. Is it vertebral vein?
Okay. So let me tell you something. Most of these structures mentioned can be damaged, right? The cervical sympathetic chain can be damaged, vertebral artery can be damaged, vertebral vein can be damaged. But what's the structure that is most intimately related with C7? No, not artery. No. Let me show you. This is C7. And this is the transverse process of C7 and the foramen transversarium of C7. What passes through that? Through this foramen in the transverse, what passes inside? Spinal what? Okay, we know vertebral artery doesn't pass there, right? The vertebral artery does not pass there because vertebral artery enters from C6 and above. What passes here, basically two things, okay? The vertebral vein and some sympathetic postganglionic nerves passing along with it. The vertebral artery is not here, it is right in front, okay? But it ascends in a tortuous path towards C6. The sympathetic chain is behind the carotid sheath, it's more lateral. It's not right, it's off to the midline, it's behind the carotid sheath, right behind it, okay? So it means if there's a fracture through the transverse process of C7, the closest structure that can be injured is the vertebral vein. It's almost assured that this structure will be injured because it moves right inside of it, okay? There's no escaping. Do you agree? Or do you have something else? Do you have any note? All right.
A patient aspirates the gastric content while in the supine position. Which of the following of the lung is most likely to be affected? It's right side, that's true. And then the I know the lower lobe is the one which affect the most, but I think it's the middle lobe because he's supine.
So he's supine, sleeping on the back. And that's, by the way, the most common situation where aspiration happens. Most people,
It's the
they
lower
have
lobe.
aspiration while they're sleeping, right? Or on the back.
It's the lower lobe.
So let's see here. Do you see? Let's focus. First, we agree that it is in the right lung.
Yeah, exactly.
All of us agree in the right lung because you know the bronchus, blah, blah, blah. Okay. But what happens inside the right lung? This is the right main stem bronchus. Do you see this person in this diagram sleeping on their back? Now, suppose you ate some strawberry juice or some apple juice or something heavy like chicken wings, whatever. So let's say you have chicken wings, or I don't like so much chicken legs, okay? That's the chicken leg, piece of chicken. When the piece of chicken move through the right main stem bronchus, the most likely two locations are, look, this is lower lobe of lung, the middle lobe, that's right lobe, upper lobe. This is upper lobe, okay? Now, it is either here That's posterior segment of upper lobe or superior segment of lower lobe. In the supine position, the two most likely locations are posterior segment of upper lobe or superior segment of lower lobe. Out of these two locations, the superior segment of lower lobe is more likely. The superior segment of lower lobe. So they can ask you even in the detail, okay? They tell you lower lobe inferior segment, lower lobe superior segment. Now you know. It is lower lobe superior segment. Okay, what if the person is not supine? What if they are prone? Like prone, like this. That is on the chest. They're laying on the chest and they happens to have some aspiration in this position. What will happen? Okay, can be a question. That's the answer. The involvement of right upper lobe is more common in patients who aspirate in the prone position. That's from NCBI PubMed, okay? When prone, the upper lobe is more likely. Upper lobe. Okay, anyway. Let's see the next question.
They're asking which of the following nerve provide the autonomic supply to the eye, and that's oculomotor nerve, right?
Yeah, there's no fun in saying it's oculomotor nerve, right? What's
The
the name?
Edinger nucleus.
Yes, what?
It have they have this parasympathetic fiber from the Edinger Westphal nucleus. They say.
Yeah, very good. So from Edinger-Westphal, then it goes to the oculomotor, then to the ciliary ganglion, right?
Yeah.
Then from ciliary ganglion, what's there?
Then there's a sphincter pupillary, right?
The name of the nerves that come from the ciliary ganglion. Yeah, that's
short ciliary nerve. Yeah.
Short posterior ciliary nerves. Okay, let's see the next one.
They ask which of the following is true regarding the Brunner's gland. They are found in the ileum. That's false. They found in the duodenum. They locate some mucus of duodenum. That's true. B.
Yeah. So Brunner gland are bicarbonate producing glands in the submucosa of the duodenum.
They're asking which of the following the histological appearance of the amyloid, and that's the Congo, right? That's true. And this, I think C is the positive green on the polarized microscope.
Yeah, there is
and
apple green.
And they specifically say, like, on the light microscope, it looked like the salmon pink, and on the light, they look like the green apple color in the polarized microscope.
Yeah, so on usual light microscope, it looks pink. It just looks pink with the same stain, by the way. It looks pink. But when you do the polarized funny stuff, it will look apple green, they call it. Apple, I don't know what's apple green, but it's apple green. What? It's green of apples. Not all apples are green, but anyway. And if you put it gross sulfur staining, it will look brown. So grossly brown. Light microscopy, pink. Polarized microscopy, apple green. Okay, let's see this question, then we have a break.
Okay, a 32-year-old athlete present with the ED after a fall examination revealed there is a bruised knee and the knee swelling. X-ray showed the multi-fragmented fracture. Which of the following is most appropriate? So it's multi-fragmented fracture, so we can go with the patellectomy. But there was one more where I read one thing. It show we need to like go through a circulage mode and tie all the multi-fragments. This is what also I hear from somewhere.
Okay, let's see the guideline here. Okay, this is the guideline. Let's read it together. Okay, they say here patellar fracture. Okay, they tell you first thing you need to know, is it displaced or not displaced? Okay, if not displaced, then nothing, non-operative, that is brace, whatever, non-operative. Okay, if displaced, By the way, usually in the patella, we allow greater degree of displacement. That is more than 2 to 3 millimeter, or there's a step off, because the patellar cartilage is very thick. It can give you the space to have a little bit of displacement without having to go to surgery, but whatever. If we have displacement, then we know what is the type of the fracture. What is the type of the fracture? So they tell you if it's transverse, like patella like this, broke into 2 pieces, transverse. Then we go for this option, tension band construct. Okay, if it is vertical, means patella is split into right and left halves, like this. Then we go for screw, right? Screw come here, and we come to bring them together. If it is comminuted, we do plate fixation. There's special plates for the patella, little plates with little screws that can bring the fragmented segments together. In the past, they used to do tension band with something that looks like K-wire. We can bring the multiple pieces together into one piece, but that's, now they think it's less functional outcome is less favorable. So plate fixation is favorable for comminution. If there is extremely severe comminution, that is the patella is 1 billion piece, then you may consider total or partial patellectomy. But patellectomy in general, we don't like it so much, because let me give you an analogy, okay? You are here on a cliff, right? That's a mountain cliff. That's a little tree here, growing here, okay? And the mountain cliff is like very sharp, steep, very steep. You and your friend decided to go hiking for some reason, okay? And unfortunately, you came on the top just fine. That's you on the top. But your friend unfortunately didn't make it. He slipped or something. He has fell down. This is your friend. Of course not happy. But thankfully you used a rope. And you are holding to the rope. Now you want to pull your friend up, but the edge is so sharp. There's a lot of friction. You can't really pull your friend. But imagine if you had a pulley. Imagine that you had, this rope is gone, but you have a pulley like this. A pulley, okay? And the rope moves through the pulley. Is it gonna be easier to pull your friend up? Much easier, right? Just need a little bit strength, working out, maybe in the gym for a couple of weeks, you'll be able to do that. It's very easy because there's a pulley. It's the same thing. The patella is the pulley. The patella is the pulley. This is the quadriceps tendon. It goes, meets patella here. Patella meets the tibia by the patellar tendon. So this patella is important for the extensor mechanism of the knee. If you remove the patella and quadriceps now directly meets the patellar tendon, it means you lose 50%, half of your strength, extensor strength. So patellectomy have functional implication. It's not a walk in the park. Patellectomy is not an easy decision to do. It means you may impair the quality of life of your patient forever, right? So it means avoid it at all costs, unless it's absolutely impossible. It's extremely severe comminution. So in this case, they didn't tell us that there is extreme or severe comminution or anything, just comminuted fracture. So if you apply the guideline that we saw together, just open reduction and internal fixation with plates. Okay, so again, guys, to summarize, if we need surgery, it must be displaced more than 2 to 3 millimeters. If it's split into upper and lower halves, tension band. If right and left halves, screw. If multiple pieces, plate. If it is impossible to bring it together during surgery, if it's comminuted, then we have nothing to do. We need to do patellectomy, but keep in mind, it's usually a bad option. You keep it in the end. Okay, guys, any questions?
I don't mind to read this.
Yeah, sure, thank you.
113. A patient presents with reduced peripheral pulses in the lower limbs and has a history of chronic smoking. How does smoking most likely contribute to this finding? So, atherosclerosis sounds possible. Arterial thrombosis, yeah, it would be if it was acute. Vasculitis, I suppose I spell them embolism. So C, D and E look acute, but generally A looks the answer if it's a long-standing with the smoking.
Yes, so smoking accelerates the progression of atherosclerotic plaques, and we know it's related to atherosclerosis because it causes endothelial injury. Is that right? Okay, let's see the next one.
A 20-year-old patient presents with acute appendicitis. On expiration, a gangrenous appendix is found. Which of the following is the initial physiological step causing the gangrene? I remember this question. I think the answer is a venous thrombosis, but it was one of those questions I didn't really fully understand.
Okay, no problem, no problem. So it just tells you about the steps in the progression of acute appendicitis up to the point where it becomes gangrenous. There are two varieties I've seen to this question in which they just tells you in general what is the cause, what is the initial step in the pathogenesis of acute appendicitis in general. Or like this question, what is the initial step which leads to the occurrence of gangrene, right? Those are different questions. I remember talking about it in a previous session about the steps of progression for acute appendicitis, but you guys would like to revise that? You want to revise that? Okay, let's revise that, no problem. So let's go here and talk about the steps. They think the main initial step which happens is that there is something occluding the lumen of the appendix. So this is our cecum, and this is the appendix, and the rest of the colon, okay? So they think that what really happens initially is that there is occlusion at the lumen of the appendix, something blocking it. This something could be a inspissated dried fecal matter called fecolith or appendiculith. So it could be fecolith, or it may be tumor, maybe like carcinoid in the appendix or adenocarcinoma in the cecum that presents with acute appendicitis. Or in the children especially, follicular hyperplasia, like if child gets upper respiratory tract infection, for instance, there will be lymphoid hyperplasia. And the wall of the appendix is very rich in lymphoid aggregates. So if they swell up, they will narrow the lumen. So anyway, the first event that happens is luminal obstruction, right? By anything. Luminal obstruction. What happens if the lumen is obstructed? Simply, secretions that are contained within the appendix are not necessarily very clean secretions. These are colonic, right? And there's a lot of colonic flora present already there. But because of stasis, right, there is multiplication of the bacteria. The bacteria multiplies, and they invade the mucosa of the appendix because they have grown to pathological levels. Is that right? And they establish mucosal infection. Remember that the appendix has all the layers. It has mucosa, has submucosa, it has musculosa and everything. So initially, the bacteria is only confined to the mucosa. There is mucosal infection or mucosal inflammation. As long as there is adequate blood supply to the appendix, bacteria cannot move further or deeper than that. So the second step is mucosal infection. But up to this point, the wall of the appendix is living and healthy. It's not gangrenous. But because of the blocked lumen and the ongoing bacterial proliferation and the exudate that is produced because of mucosal inflammation, all of that accumulate in the lumen of the appendix. And the pressure, step by step, starts rising more and more and more and more. This pressure compresses the walls of the appendix. There's compression from within because the lumen is under high pressures. So there is compression of the wall of the appendix, right? The walls of the appendix are compressed because of high pressures inside. And also the lumen is obstructed, so it cannot even decompress. If that happens, veins are low pressure channels. Is that right? The pressure in the vein is lower than the pressure in the artery. So the veins within the wall of the appendix, they become compressed, right? The veins in the wall of the appendix, they become compressed. And if they are compressed, arterial inflow is still going on. The artery is still feeding in blood to the appendix because it's still patent, has higher pressure. So there's blood coming inside, but not going out, right? This establishes venous ischemia. This establishes venous ischemia because there's accumulation of metabolites and toxic waste products, and ischemic changes happens. So ischemic changes happens once the veins get obstructed. When the veins gets obstructed, that's the first thing that happens. Okay, so venous obstruction. But things become even worse. When the veins are obstructed, there's also congestion. And that adds more to the pressures, such as that there will come a point where those pressures overcome the arterial pressure. And here, even arterial inflow is obstructed and ischemia is worsened even further, right? So next step will be arterial obstruction. And finally, the appendix will perforate, usually near the tip, because the appendicular artery is in the artery and the tip receives the last blood supply and is the worst to be affected. And we end up with a perforated gangrenous appendix. Clear? No problem? So it means in this question, they're asking us this. They're asking us this, not this. Okay? So be careful about the wording of the question. Read it carefully. Understand what they want first, then answer. Okay? Okay, let's see the next question.
43-year-old woman has a mass on the right lobe of her thyroid and a fixed pulsatile mass on the right side of her forehead. Which of the following is the most likely diagnosis? So pulsatile mass, it will be
Follicular.
follicular. Yeah.
Okay, yeah, so follicular have a tendency to go through blood, and that explains the lump in the neck and the lump in the forehead. And it's also very hypervascular, right? The deposits. So they tend to be pulsating as well. All right, let's move.
Patient presents with disseminated intravascular coagulation, DIC. Which of the following blood products or therapies may be indicated? So I think the platelets get used up. So C, you want to give platelets maybe?
Cryoprecipitate. Package cells, maybe.
Dr. Nora, are you saying something? I think you forgot your microphone open. Yeah. Okay. So DIC, disseminated intravascular coagulation. Horrible condition. It's a consumptive coagulopathy, right? In which there is widespread activation of the coagulation cascade with consumption of platelets and almost all or all the coagulation factors. Is that right? So
Yeah.
usually in DIC, there is a bleeding as well as thrombosis, because thrombosis, of course, we know, but bleeding happens because already platelets and coagulation factors are consumed. Nothing to maintain the integrity of the coagulation system anymore, right? So, but usually there is balance. Usually some people tend to trend more toward thrombosis, and some other patients you will come across that they trend more towards bleeding. Okay? But usually there's an element of the two, a mix of the two. So it means what? It means because the coagulation factors are consumed, we need to replace them. We need to replace them, right? What blood products come to your mind that provide all of the coagulation factors that are consumed in the process of DIC? What blood product would you think about that will be able to give you that?
That's why I'm a bit confused. I think you need to give fresh frozen plasma and platelets, and that obviously isn't an option. I'm not sure.
Yeah, I'll come to that. Thank you for now. I'll come to that. I know that. But fresh frozen plasma is usually given in most cases of DIC because in DIC, most of the coagulation factors are deficient and consumed. There isn't any other blood products that will give you that. The platelets, we do not like to give them routinely in DIC. There are specific indications for platelet transfusion in DIC. So it is not in every case, but almost every case we give them fresh frozen plasma. Platelets are given if, only if, the patient is actively bleeding and platelet count is less than 20. Or patient is not actively bleeding and platelet count is less than 50. Of course, 50,000 cells per microliter, I mean. Okay? So platelet has a place in the management of DIC, but a very specific place, not in every case. Okay? So it means we manage with fresh frozen plasma. Almost all cases receive that. Platelets only under these conditions. We can also add more. We can give heparin in patients who are mainly thrombotic manifestations. But be cautious. Heparin is given with cautious because it can worsen bleeding, right? So heparin may be used under very specific circumstances where there is mainly thrombosis and minimal or no bleeding in that particular patient. Vitamin K doesn't have a place in the management in general in DIC. Okay, agreed, guys? No problem? Okay, let's see the next one.
So, patient has a median nerve injury in the carpal tunnel. Which of the following findings is most likely to be seen? So both of those, metacarpal flexion and sensation over the thumb, couldn't they both be affected? I'm a bit confused.
Okay, let's see. So median nerve is injured within the carpal tunnel. Which function or finding is most likely seen in carpal tunnel syndrome? Yes, guys. Thinner muscle wasting, loss of finger adduction, loss of wrist extension. Okay, so we have thinner muscle wasting is a finding in carpal tunnel syndrome that is possible, right? Because median nerve supply thinner muscles. Loss of finger adduction, not so much, because adductor pollicis is by ulnar nerve. Option C, which is loss of wrist extension, no, because wrist extension is radial nerve. Loss of sensation over the thumb, yes, it can happen. Also, loss of metacarpal flexion, no, because usually the long muscles are the ones that do that. Yes, you have a question. Sorry to interrupt, Doc, but in case of DIC, you shouldn't be giving cryo. Yeah, it's also cryoprecipitate is given, especially if predominantly there's hypofibrinogenemia. I agree with you. But what about the other coagulation factors which are consumed in the process? So guideline-based is that fresh frozen plasma is usually the favorable blood products to be given in DIC to replace all of coagulation factors, because simply all coagulation factors are affected. But I agree with you, cryoprecipitate is given, especially if the main issue was with fibrinogen, hypofibrinogenemia, mainly, because it's rich in fibrinogen. Okay? So, coming back to carpal tunnel syndrome. In carpal tunnel syndrome, usually what is the initial or most common manifestation in carpal tunnel syndrome when we talk about it? Patient-wise, clinical picture, most common thing.
Yeah, I think even now, I think thinner muscle wasting is the main one. I was just a bit confused.
No. Thinner muscle wasting is usually an advanced feature of carpal tunnel syndrome that may warrant even surgical decompression for that. But most patients present with sensory symptoms first. The majority of patients present with sensory symptoms. Paresthesia, especially when there is flexion at the wrist, or if there's tapping in front of the wrist. This is the most common manifestation that you see every day in your clinic, right? So B, in my opinion, is most likely, as the question wants, most likely manifestation would be B, in my opinion. What do you think, guys?
Yeah, I agree with you. Yeah.
Sensory symptoms much more common. Let's see the comments. People are commenting. Locally distinct, said, again, sorry, but median nerve transecting at wrists. I don't know what you mean, but yes, median nerve traverses the wrist within the carpal tunnel. If they say over the thumb, how to decide palmar surface? Well, they didn't specify if it's palmar or dorsal surface of the thumb, but median nerve does supply the thumb. We cannot assume that. Muhammad said palmar not affected. No, palmar affected. The palmar surface of the thumb is affected, guys. Palmar surface of the thumb in carpal tunnel is affected. The central. Yes, Muhammad. Now I agree with you. Palmar branch of median nerve is not affected. So what? Let me clarify I think you guys are confused. Let me clarify that to you, okay? Let's revise some of the anatomy first. This is distal radius. And this is distal ulna, and ulnar styloid and radial styloid. The carpal tunnel, I'll just draw it like a tunnel like that, okay? Without drawing the details of the bones. It's like a tunnel over here. Like this. Okay, you get that? Like a tunnel. This is a tunnel. And we know the flexor retinaculum spans this region. So imagine it's on top of the flexor retinaculum. Here's median nerve. Median nerve's coming like that. That's median nerve. Just before it gets into the carpal tunnel, it gives palmar branch. This palmar branch moves on top of the flexor retinaculum, not inside of the tunnel. We will follow what happens next. Median nerve continues inside of the carpal tunnel, generally anterior to the 9 tendons that pass here. So because it's inside, I'm going to draw it in a dashed line. Then we go to the hand. I'm just going to draw the hand over here, right? This is the thumb, right? And this is the other fingers. That's index. That's middle. That's ring. That's little. Okay. Now, median nerve itself, after it emerged, first it enters the central compartment of the palm, just deeper to the pulmonary aponeurosis. And then here, it's going to give a recurrent branch. This recurrent branch will supply the thinner compartment. Then it breaks into digital branches. Okay, there's digital branches going to the thumb, digital branches going to the index finger and middle finger, and medial part of ring, lateral part of ring finger. These digital branches have two functions: sensory supply to the palmar surface of thumb, index, middle, and lateral 1/2 of ring. Plus, they move on also the dorsal aspect. They move also onto the dorsal aspect of the same digits to supply skin over the dorsal phalanges, over the dorsal surface of the distal phalanges, okay, of the same fingers. What about the palmar branch? The palmar branch, after it enters the hand, it supplies the central base of the palm, this region. I'm going to give it this color. It supplies the central part of the palm at the base, toward the base of the palm. This will be spared in carpal tunnel syndrome, I agree with you. But thumb sensation will be lost because thumb sensation is supplied by digital branches, not by the palmar branch of median nerve. Do you agree with me, guys? No problem? Okay, good. So in carpal tunnel syndrome, this is not affected. The radial part of the thumb is supplied by the radial nerve. But in the question, they didn't tell you, Dr. Muhammad, palmar or dorsal. They just tell you sensation over thumb, which is still a perfectly correct sentence. Nothing wrong with that at all. Okay? Okay. Let's see the next one.
Sorry, can I interrupt, please?
Yes, Fabio.
In terms of sensation over the thumb, there is a portion where the radial nerve is checked in regards to sensation over the thumb. So when to realize whether it's median or radial in terms of option B.
In terms of option B, they told you there's loss of sensation over the thumb. Is that right? They did not specify which part of the thumb that should be lost. Like, for example, loss of sensation over the dorsal surface of the thumb. It will be wrong. That would be radial nerve. Or either. So it means it is not a wrong statement if they tell you loss of sensation over the thumb. It's not a wrong statement. Median nerve injury can cause that. I agree, it's palmar surface only of the thumb, but it is over the thumb as well. Is that right? It's not a wrong statement. I mean, option B is not a wrong statement. If they have specified, I would have agreed. Okay. All right. Let's see the next one.
Yeah. So which of the following best describes the mechanism of action of topical steroid agents? So I know this one because arachidonic acid is the precursor to inflammatory. So that is released by B. So inhibition of phospholipases would help reduce inflammation.
Yeah, that is good. Very excellent. Yes, you have a comment, Dr. Muhammad. Let me see that. So what more correct? Can you make thinner wasting other than recurrent branch of median nerve? Thinner wasting is not a common manifestation in carpal tunnel. It usually happens in advanced carpal tunnel syndrome in neglected cases. It's not something that you see every day in the clinic. It's a manifestation, but it's not the most likely that you see. In most of the patients that you see is sensory manifestations, not motor. Motor manifestations happens late in carpal tunnel. Okay? So about that question, how steroid happens, it is so simple. Okay? What happens is that this is the plasma membrane that has phospholipids. One of the important phospholipids that are present is called arachidonic acid. It's called what? Arachidonic acid. Arachidonic acid. Now, arachidonic acid is the precursor from which many of the inflammatory mediators are made, specifically eicosanoids that are prostaglandins and leukotrienes. So first we need to extract the arachidonic acid from the plasma membrane. This is the role of phospholipase A2, specifically phospholipase A2. Phospholipase A2. That will release the arachidonic acid from the plasma membrane. Now, arachidonic acid, we have it here free. It can go either two pathways. One pathway is called lipo-oxygenase pathway, and the other pathway is called cyclooxygenase pathway. Okay? The lipo-oxygenase pathway, you end up with a lot of products collectively called leukotrienes. They're also inflammatory mediators. And cyclooxygenase pathway, you end up with a lot of products collectively called prostaglandins. They have different functions. Okay? This is the basic situation. So how steroids work, how they are anti-inflammatory, they block this enzyme. They block this step. They block phospholipase A2, so arachidonic acid is not produced in the membrane. So leukotrienes and prostaglandins alike will be reduced with steroids. On the other hand, non-steroidal anti-inflammatory drugs target this step. So it means if they ask you in the exam, non-steroidal anti-inflammatory drugs reduce prostaglandins? Yes. Do they reduce leukotrienes? No, in fact, they increase leukotrienes because that arachidonic acid which has been produced will be shunted preferentially toward the leukotriene pathway, which is uninhibited. That's why it's contraindicated in asthma. Is that right? Because asthma person, if you give them non-steroidal anti-inflammatory drug, their arachidonic acid will be mostly shifted to the production of leukotrienes, which mediate the bronchial inflammation seen in bronchial asthma. So when asthmatic person takes non-steroidal, they have a flare in their asthma. They have acute exacerbation. Okay? Simple, right? Let's move to the next one.
An elderly patient with a femoral fracture who smokes undergoes surgery for the fracture. Post-op, he develops pulmonary embolism, which is following his biggest risk factor for PE. So I remember us discussing this one, and there are a few here that are, but probably recent surgery is.
Yeah, so yes, I agree with you. Recent surgery, especially a major orthopedic operation like this, is very high risk for pulmonary embolism because of many things. First, the immobility, right? The surgical stress is a hypercoagulable state in its own, and endothelial injury that can happen during the surgery. Together, they can increase the risk of DVT and PE afterwards. So it is already well established that recent orthopedic operation, especially on the pelvis and lower limbs, is amongst the highest risk factors of DVT and PE. So simple. Let's move.
A 53-year-old man presents with nodule on his chin. He is concerned because it has grown extremely rapidly over the course of the preceding week. He has a swollen red dome-shaped lesion with a central defect that contains a keratinous type material. Yeah, okay. So that I think is A. I always get confused about this. I think it might be A, but obviously it looks E. The word matches E, so I'm a bit confused because the character can.
Okay, so the correct answer is E. This is called keratoacanthoma. Yes, Fabiha, the question is simply a 53-year-old man that presents with nodule on his chin, concerned it has grown extremely rapidly over the course of the preceding week. Had on examination has a swollen red dome-shaped lesion with a central defect that contains a keratinous type of material. So this is a very accurate description they've given to keratoacanthoma. Keratoacanthoma is a condition in which there is a very rapid growth that happens, but it's usually symmetrical and dome-shaped, right? In the beginning, it appears like a nodule, like your regular nodule. But after that, this nodule enlarges so much, and in the center, it becomes necrotic and forms a crater, right? Like this. And it is filled with keratin, a keratin plaque. This condition is very worrying because it resembles cutaneous malignancy so much. It's not malignant, but because of this, it always warrants excision. Keratoacanthoma treatment is always excision because the nature of the rapid growth, we need histopathological evidence to exclude malignancy. So if they ask you what's treatment of choice in this case, you answer excision, okay? Excisional biopsy. Okay, let's see the next one.
A woman undergoes a Pfannenstiel incision after the rectus sheath is retracted, which layer is encountered next. So you've got the transversalis fascia under the rectus abdominis muscle. So I will go for C there.
Okay, yes. So what we do in Pfannenstiel incision, after moving through the skin and sub-Q and everything, we come to the linea alba, split that and retract, right? What we see underneath would be the transversalis fascia. After that, extraperitoneal fat. After that, parietal peritoneum. Okay, let's move to the next one.
A 3-year-old boy is brought by his mother complaining that one testis is sometimes palpable and sometimes not palpable. The underlying pathology is due to hyperactivity of a muscle derived from which of the following? The muscle derived from. I'm going to go for the external oblique aponeurosis, but it's a bit of a guess because I've
internal oblique muscle.
Okay, yeah. So it is very obvious that this is retractile testis, and it is due to hyperactivity in the cremaster muscle. It's a very common condition in children. Sometimes don't get fooled by that, because in undescended testicle, when you hold the testicle usually at the neck of the scrotum and bring it down, it may come down with you. It comes down, but with tension. And when you release it, it immediately jumps back up. That's in true undescended testes. But in retractile testes, yes, the testicle is up, but when you hold it and move it down to the bottom of the scrotum, it moves with ease. And when you release it, it doesn't snap back like a rubber band, right? So that's clinically how you differentiate between the two. But of course, because this is obviously retractile most likely, cremaster muscle, we know it is derived from the internal oblique muscle. Is that right? Yes, Fabiha?
In the previous question, 121, the question asks, what is the layer after rectus sheath? Will it not be rectus abdominis muscle?
If you take it in this sense, then yes, but that's not what happens in Pfannenstiel incision. We don't do that. Like, let me tell you, this is the rectus abdominis muscle, right? That's the umbilicus. This is linea alba. Pfannenstiel incision is made below the level of the arcuate line. So there's no posterior rectus sheath. Is that right, Fabia? Okay, so we do curvilinear incision with a skin crease, then we move through skin, superficial fascia, and then after that we will encounter the anterior rectus sheath. We do not open the anterior rectus sheath, we open the linea alba, and then retract the muscle with its sheath, with the anterior sheath. So after that will be transversalis fascia. Okay, so in Pfannenstiel incision, we don't make a big incision over the rectus sheath and open that, then open the muscle. That doesn't happen. Okay. Right, let's see the next question.
A 42-year-old multiparous woman attends her GP with pelvic discomfort, feeling of something coming down. Which anatomical structure normally gives the most significant direct support to the uterus? I remember this question coming up a few times, and sometimes they give, I know what the answer is, cardinal ligament, but I haven't looked through the options yet, because sometimes they give it in a different way, or they don't have that in the options. So let me have a look. You see here, I would be looking for cardinal ligament and I can't find it. And this is what I see this question a few times.
Oh, it's there. The cardinal ligament is the same as the transverse cervical ligament. It is the same.
Oh, right. That's what I didn't know. Yeah.
It can be called cardinal ligament. It can be called transverse cervical ligament. It can also be called ligament of Meckel, but different name to the same thing, right?
Okay. That's why I really didn't like this question, because I've seen it in a few different ways. And it's kind of confusing. Yeah.
Okay. So look, guys, it is the uterus is held in the pelvis because mainly of what? Mainly of the cervical ligaments that attach to the uterus, cervix, and links that to the endopelvic fascia. Actually, these cervical ligaments are thickenings of the endopelvic fascia without moving in details, okay? But there are pubocervical ligaments, right? And there's also posterior sacral ligaments and transverse cervical ligaments. Out of these three, the transverse cervical is the most significant, even according to the Gray's Anatomy, right? They tell you explicitly that this is the most significant structure which supports the uterus, and weakening in this structure is known to contribute significantly to uterine prolapse. Okay? So I hope there's no confusion to this question. You never choose E. Transverse perineal muscles are very thin, flimsy muscles in the deep perineal pouch. You never choose that. Levator ani, yes, levator ani gives significant support to the uterus, but not attached to the uterus. Levator ani muscle basically support almost all the pelvic organs inside of the pelvis, right? But it doesn't attach to the uterus directly. So if they ever tell you like indirect support, what's the most significant thing that doesn't attach to uterus but also supports it? Then you go for levator ani muscles. This is the main framework of the pelvic floor, right? That holds everything inside. Okay, let's move to the next one.
A young man in an RTA sustains an extensive flexion injury of the cervical spine. He has loss of motor, sensory, and anal tone below the level of injury, but the bulbocavernosus reflex is intact. Which of the following best describes the type of spinal cord injury?
Okay, so we have incomplete spinal cord injury, spinal shock, complete spinal cord injury, central cord syndrome, Brown-Séquard syndrome.
So I think it's C, complete spinal cord injury.
Yeah, very excellent. Very nice. I think, I don't know if I have to talk about that topic. It's up to you guys. If you know it already, we can save time and skip. If you want to talk about spinal cord injury stages and everything, we can talk about that. It's up to you. Okay. So I'm going to simplify the topic. It's in detail in the lecture, right? You can find that in, I think in orthopedic section. But I will talk about it, okay? It's simple. It's very simple. Let me tell you. This is brain. This is brainstem. And this is spinal cord. Right? Okay. To simplify the situation, there's a motor cortex in our brain. Right? We will resemble that by one cell. There are cells there. There are neurons there. In the motor cortex, which is in the precentral gyrus, in the frontal lobe of the brain. Now, these neurons are called upper motor neurons. These neurons are called upper motor neurons. Their axons are surprisingly very, very long. Okay, they descend through the brain, through the brainstem, and in the spinal cord or somewhere, they should meet a lower motor neuron. They should meet a lower motor neuron, right? And that lower motor neuron comes out and supply a muscle, right? This is the basic situation. When you want to contract this muscle, your upper motor neuron should fire, and that should activate lower motor neuron. Lower motor neuron should make this muscle to contract, right? But of course, it's not as simple as that. There's basal ganglia, cerebellar input. It's more complicated than that, but we don't need that. We don't need to know that. Okay. Suppose we make an experiment. We cut the spinal cord completely, cleanly, okay? In this level. Now, spinal cord have been sectioned totally above the level of this particular lower motor neuron. Okay. Now, the moment we do that, the moment we cut the spinal cord, everything below the spinal cord stops working. Everything. Motor function, sensory function, autonomic function, reflexive function, everything below the spinal cord level of injury, function is lost. Okay? It's lost. This is only temporary. Okay? This situation is only temporary. It is not lost forever. The functions will recover, but they are no longer under control of the higher neuronal centers. They will recover, though. It is like if, suppose you work in a hospital, we all have that toxic consultant, isn't it? This toxic consultant, of course, has to be bald. This is our toxic consultant. We'll make them bald. Those are not ears, they're just hair, okay? Those are toxic consultant. We all hate that. Of course, you have glasses. Typical situation. Always angry. If you forgot to do the OT listing, they will make your life horrible. If you make a mistake in the OT, they will basically kick you out in front of everyone. Have a terrible day. But this toxic consultant is keeping everyone under control. Of course, you'll lose your job if you do something. So you are polite all of the day. You can't say no. You can't make arguments. But you are quiet, nice, and polite. So those are us, okay? Inhibited. Everyone is in line and inhibited. Now imagine with me that this guy over here, the consultant, unfortunately, they die, okay? Unfortunately, they die. Maybe car accident, or let's say they get sick at home, okay? We're not that evil. We still love them. So let's say they're sick at home. At that moment, you come to the hospital in the morning, and suddenly that scary monster is not here anymore. So first, you're shocked. You can't believe it. You can't believe what's happening. So you just stop working at all because you're shocked. You don't know what's happening. Okay? But after a while, you become happy. No more restrictions anymore. You can go here and there to the cafeteria. You can leave whenever you want. You can come whenever you want. You're late. You become chaotic. Nobody is there to control you. The entire hospital becomes a chaos. Is that right? This is exactly what's happening in the spinal cord. In the beginning, the consultant is gone, so you're shocked. Okay, nothing is working in the hospital. That's called spinal shock stage. Spinal shock stage. All functions lost, as I agreed with you. All right, but when you realize that this monster is gone, you become chaotic, and the entire hospital runs into trouble. These lower motor neurons will firing, and that leads to spastic paralysis of the muscle. The muscles becomes spastic. Also, that goes for other things as well, like reflexes. They become exaggerated. The tone becomes heightened, hypertonia. All right? And even the autonomic nervous system goes on fire, especially the sympathetic nervous system. It fires so much, such as that there's hypertensive crisis. We call this autonomic dysreflexia, especially above T6 level. That's what troubles happens, because if you go above T6, most sympathetic neurons are below the level of lesion. Also, reflexes will not be there, including the bulbocavernosus reflex. What is bulbocavernosus reflex? Everybody loves that reflex. Simply, when you tug on the penis or cause electric stimulation of the glans penis, the anal muscle contract. The anal muscle contract. This is entirely a reflex within the spinal cord. It doesn't need higher centers. So it is very simple, right? You do the stimulus here, goes to the spinal cord, and then comes back to the anal sphincter and causes it to contract. Of course, during spinal shock stage, this reflex is not there. But when the spinal shock stage is ended, it can typically take a few days to a few weeks. When it is ended, the bulbocavernosus reflex comes back. The presence of the bulbocavernosus reflex doesn't mean anything. It doesn't mean anything. It does not mean the injury was complete or incomplete or anything. It just means that spinal shock stage has ended. That's it. Okay? That's all what it tells us. Okay, then we come to the conclusion. If the spinal cord is completely cut here, when you go to the sacral segment, the last segments in the spinal cord, right? S4 and S5, the sacral segment, last caudal segments of the sacrum. If the spinal cord is completely cut, do you think these segments will work or be under control of higher centers? Of course, no, right? No. You will not be able to perceive perianal sensation. You will not be able to perceive deep anal pressure or voluntary anal sphincter function. I will come to that, okay? Don't worry. But what I need you to know is that when there is complete spinal cord injury, the distal part of the sacral spinal cord will lose function. But if there is any degree of incomplete spinal cord injury, like central cord syndrome, like Brown-Séquard, like anterior cord syndrome, whatever, there will be some function retained in the sacral segments. We call this sacral sparing. Sacral sparing. Very important topic in exam. Sacral sparing simply means what? Means three things. Number one, perianal skin sensation. Perianal skin sensation. Number two, anal motor function. Number three, deep anal pressure. Deep anal pressure sensation. So perianal skin sensation, just simple. Right in the anal verge, you touch and check if patient can feel that. Anal motor function is simple. You put your finger inside and ask the patient to squeeze. If they're able to squeeze it, it means it's voluntary anal function. Voluntary, patient can do it. And deep anal pressure, also when you put your finger inside in the rectum and put some pressure on the rectal wall, the patient can feel that. This is called deep anal pressure sense. If any of these is present, it means incomplete injury. So bottom line, sacral sparing equal incomplete injury. No sacral sparing, complete injury. Okay? This is the basic information that I want you to know. That if there's sacral sparing, it's incomplete. If there's no sacral sparing, it's complete. Right? Simple? Very simple. Now, unfortunately, that's not enough for the exam. You need a little bit of more detail, okay? A little bit more detail. I want to take you to a tour in the spinal cord. A very quick tour, okay? This is spinal cord. Dorsal horns, ventral horns, etc. You know, here on the side, we have two important tracts. There's a tract over here, This tract is called corticobulbar tract. It's called what? Corticobulbar or corticospinal, depending on level. So let's say corticospinal tract. This is corticospinal tract. What's this tract? It's simple. It's this one, guys. Right? It's this tract. It's the tract that connects upper motor neuron to lower motor neuron. Right? That's it. And next to it, just next to it, is another tract. This tract is called lateral spinothalamic tract. Lateral spinothalamic tract. What I want you to know from this diagram is just a simple information that the lateral spinothalamic tract is just next to the corticospinal, just in the neighborhood of it. What is this lateral spinothalamic tract? It's simply, it carries pain and temperature sensation, right? Lateral spinothalamic tract carries crude touch, pain sense, and temperature sense. Oh, but there's a very important thing here, which is out of these three modalities of sacral sparing. Now listen to my question very carefully. Out of these three modalities, which one best predict motor recovery after spinal cord injury? Of course we know that if someone is injured, they break their spine, they're in a wheelchair, and they're going through rehabilitation programs to walk again, right? That we see that in movies. Now, this person, what can you do, a test you can do to this person to predict that he or she can walk again or can have motor recovery in the future better than others? It's so simple. You take a pinprick, right, and prick the patient in the perianal skin. That is pinprick, perianal sensation, specifically pinprick, not touch. Because pinprick sensation, if patient can feel that, it means this tract is okay, the lateral spinothalamic tract. And if this tract is okay, it means corticospinal tract is likely okay because it's just next to it. However, if you prick the patient in his perianal skin and doesn't feel it, that's bad sign and not good, because it means this tract is gone. And if it's gone, right, this is gone also. This is also gone. So no motor recovery, unfortunately. That was a question in a previous exam. Which of the following modalities best predicts motor recovery? Many people went crazy over that question. It's simple, right? Would you agree, guys? Really simple, right? Okay. Any questions? No questions. All right. So if you come back to the question here, it's so simple. Let's revisit it. It just told us that, young man involved in RTA, there is something in the spine. On examination, he lost everything. Then the bulbocavernosus reflex is intact, means not in spinal shock stage. So it means we can do formal testing for sacral sparing. By the way, sacral sparing, you only do it after the bulbocavernosus reflex have returned, because I've agreed with you that before it returns, already all functions are lost. We are in the spinal shock stage, okay? So you can only formally test for complete versus incomplete injury after this reflex came back. So they just told us he lost motor, sensory, and anal tone below the level of injury. All functions have been lost. And bulbocavernosus reflex is there. So it means injury was complete, right? No sacral sparing, injury complete, as I agreed with you. Okay, let's see the next one.
A 25-year-old woman sustains a suprasyndesmotic fracture of the fibula. On examination, there is swelling over the lateral malleolus and medial ankle pain. X-ray of the ankle shows widening of the medial ankle joint space. Which of the following ligaments is most likely damaged? So the lateral malleolus, medial ankle pain. I think it may be the deltoid ligament.
Oh, that's impressive, yes.
Brunner.
Yep, that's correct answer, deltoid ligament. Anyone can tell us why?
It's found in the medial ankle joint space.
Yeah, so it's so simple. Let me tell you. Let me tell you something. Yeah, Mason-Neuve, right? That's Mason-Neuve fracture, doctor. Yes, I agree with you. Let me tell you something. I want to take a cross section in the ankle, okay? Where this is the trochlear surface of the. Okay, maybe we go here better for drawing this one. Horrible. Yeah, that's better. This is trochlear surface of talus. Locally distinct, I will come to the detail, don't worry, okay? This, guys, is coronal section in the ankle, you get me? Such as that, this trochlear surface of talus, okay? And suppose this is the fibula, and this is the tibia. Okay, this is the tibiofibular syndesmosis. And this is medial, right? That's lateral. This is deltoid ligament, right? I'm just going to make it simple diagram like that. That's deltoid ligament. It's on the medial side. It connects medial malleolus to talus, so that's deltoid. And without details, that's lateral ligament, okay? I don't want to go through anterior talofibular, posterior talofibular. Just, this is lateral, okay? Lateral ligament, all of them together. Talus is inside a socket. Talus is inside a socket, this socket, right? Which is formed by tibia and fibula, distal part. This is called ankle mortise, where the talus fit, trochlear surface of talus fit. Now, normally, this space and this space should be equal. The spaces inside the joint should be equal. What holds it inside is these ligaments, deltoid and lateral ligament complex, is what holds the talus inside. If there is injury here to the deltoid ligament, suppose deltoid ligament completely rupture. Okay? If it ruptures, it means it cannot hold talus in place more, right? And talus tend to sway laterally. You get me? And vice versa. It is like if you put pressure in inversion or eversion, you will be feeling it. So widening in the medial joint space makes us suspect deltoid injury. Syndesmotic injury, the two bones break apart, right? These two bones, they will move apart, right? And talus will jump up. It will not make an inequality within the joint space itself, medial or lateral. This is referred to as, by the way, if you want to know, Mason-Neuve fracture. Have you ever heard about it? Where there is a high fibula fracture and deltoid ligament disruption? That's Mason-Neuve fracture. Okay, let's move. Yep. Yes, Dr. O with me. Okay, maybe he got busy with something. Anyone would like
Sorry,
to...
I'm back.
Yeah.
12-year-old
Yeah.
child, unless someone else wants to read. If someone else wants to.
Okay, if you're tired, it's okay. If someone else wants to read, it's fine. I don't want to put too much pressure on you. Unfortunately, you've been reading for
if
a
anybody
very long
else wants to, they can. But okay, I'll carry on with this one. 12-year-old child is brought by his parents with sudden onset of unilateral scrotal pain. The left testis is elevated and assumes a horizontal lie. Not quite sure what that means. What is the most appropriate treatment? I'm not really sure I fully understand this question.
Okay, I will tell you. Have you ever seen church bells? You know the church bells? In the church, you see a big bell at the top. And when prayer time or something comes, the bells start ringing, right? And the bell, I think it looks like this, right? And there's a little clapper inside, right? Like a string and a ball or something. And when it moves side to side, it starts doing the sound, right? Okay. There's a situation which happens congenitally in the testicle called clapper in a bell deformity that resemble the church bells. What does that mean? Now, it's simple. Look, guys, the testicle, this is testicle, okay? And I want to take cross-section like this, and we look from above, right? So testicle in a cross-section is like this. This is anterior, this is posterior, okay? Okay, that's posterior here. You know tunica vaginalis, right? The remnant of the processus vaginalis. It covers the testicle in its anterolateral surfaces only. That it has a layer which is adherent to the testicle, very, very well adherent to the testicle. And then it reflects like this and forms another layer. The layer which is adherent to the testicle, that's the visceral layer. And the layer outside is called the parietal layer. This is called tunica vaginalis. It's derivative of the processus vaginalis. The back is naked. The back doesn't have anything. It just have the loops of epididymis on the back. This configuration is so important to keep the testicle in a vertical lie, like this. Okay? So important to keep the testicle in a vertical lie. But sometimes the tunica vaginalis goes way back and invests the whole testicle. Okay? It's like this. The tunica vaginalis goes way back and invests everything. And the testicle basically is swimming inside. So we will, if we see it like that, in this way, if we see it like this, that's testicle lying in a horizontal lie, that's epididymis, and this is vas or cord, right? Spermatic cord. Tunica vaginalis is like this. Goes way up, goes way up, and the testicle is just hanged like this. So it means this is called high investment of tunica vaginalis. It goes way back, such as that it can twist about this axis. Twisting is easy, right? Now it's easy. So this is something you can diagnose so easily. You just ask patient, you want to inspect the scrotum, and when you look at the patient's scrotum, the testicles are not lying vertically, they are lying horizontally. It's very characteristic. You can look it up at Google. This problem is a congenital problem that predisposed to torsion, and it is usually bilateral. So it means in most cases of testicular torsion, there's underlying anatomic predisposition that is congenital. And when we want to treat the situation, it means both sides must be fixed because both testicles are predisposed. So even if you fix one side, in the future, the other side will present with torsion. So we will make a transverse scrotal incision, explore both hemiscrotums, and fix both testicles in what's called dartus pouch, right? We fix the testicles in dartus pouch, means in a pocket in the dartus muscle, to make sure, with non-absorbable suture, of course, to make sure that it doesn't come back again. Torsion doesn't happen again. Okay? So it means, in this case, we need bilateral exploration and bilateral fixation. Okay? Same principle, yes, locally distinct. Same principle apply to adults. Okay.
The next one I know because it's the farmer anthrax question. So 57-year-old farmer presents unwell, has on his right hand a dark coloured Ishar edema, and which of the following is likely responsible? So this is A, Bacillus anthracis. Comes up a lot, this question. So
Yeah, so no fun in that. Let's move.
45-year-old man with end-stage renal failure undergoes a cardioveric renal transplant. The transplanted organ has a cold ischemia time of 26 hours and a warm ischemia time of 54 minutes. Post-operatively, the patient receives immunosuppressant therapy. 12 hours after the operation, the patient develops anuria. I've forgotten the cutoff for how quickly, but 26 hours seems quite a long time.
Okay.
Yeah. After irrigation with the saline, flow resumes. So that would make you think it was just an occlusion. Yeah. So I'll go for C then, but the 26 hours threw me. It seems a long time.
Yeah, it can happen. Some clots can form and blocks after the operation. Some clots can form due to the bleeding that happens. And it is so common. It's the commonest cause of anuria following renal transplant. Simply when you irrigate, urine comes back. So that's reassuring, right? It's a simple case. Okay.
54-year-old woman presents with abdo pain and examination reveals a strangulated femoral hernia. Which of the following structures lies lateral to the neck of the femoral hernia? It's the femoral, I'm going to say vein, but it might be the ligament. I get these mixed up. I have to remember this. I'm going to go for vein, but I could be wrong on this.
Yeah, so it's like in every exam, right? This question, asking about the boundaries of the femoral ring in every exam. So remember, anteriorly is what, guys? You tell me. And anterior?
It's the inguinal ligament anterior.
Okay, inguinal. On the back?
Medial ligament.
Okay, and medial?
Lacunar ligament.
Okay, and lateral is vein, right?
Right.
Femoral vein. Muhammad wants to look up this question again. It's so simple, Muhammad, let me tell you. Someone had renal transplant. This entire story, you don't need it. Warm ischemia time, you don't need all of that. What you need is in the end, right? This patient have received a cadaveric kidney transplant. Afterwards, there is anuria, meaning not a drop of urine is coming out, anuria. But when they've irrigated, urine came back. So it means it must have been something blocking urine. It's not like renal artery thrombosis or something bad, right? It is simple situation. So it is just occlusion. That's it. Okay, you want to see the question? No problem. Here you go. You can take screenshot also. This one and this one. Okay. Okay. Let's see the next one.
18-year-old man sustains pretibial flap laceration, which is 6 centimeters times 2 centimeters. The tibia is exposed with intact periosteum. The wound edges cannot be approximated. What is the best course of action? Okay, so I do remember this question. Like you discussed it and it came up in the exam. And ideally, I think you want to do a, I think it's a free flap. I would go for D, but I think we just said that we need a team to do this. If it is D, it's not something that basically all have at hand, though, is it, to do a free flap? Would they be able to do that? Would it need plastics?
But periosteum is there, Doctor. Why you want to make it more difficult? Periosteum is there, so why you want to go for a flap which is more difficult, right?
Yeah, sorry, I'm mixing this with another question. Okay, yeah, so you can use the periosteum is there. You could use a split. You could go for
split thickness. Split thickness skin graft. Okay, let's see the next one.
Which of the following tissue types are typically found in Meckel's diverticulum? There are two types, gastric and pancreatic, but I think gastric is the most common. So I'll go for A.
Yeah. But I just want to tell you something, that yes, the most common ectopic tissue in a Meckel is gastric mucosa, okay? But most of the people, there is no ectopic tissue. In most of the people, there's no ectopic tissue. So I just want to thank also the people who were with me in this exam who did this very great recombination of the questions. I thank them so much. They really did help with that. But some of them in this question, there's some conflicting, in the wording, they didn't agree. Some of them told me it was which of the following ectopic tissue types is typically found in Meckel. So usually it's gastric. In this case, answer will be gastric. But some other people told me that we didn't see this word. We didn't see ectopic word in this question. It just tells us what's the most likely mucosal lining of a Meckel. In that case, it will be ileal mucosa, which is the most common situation, because look, in 98% of the cases, it remains asymptomatic the entire lifetime because it only have ileal mucosa, no ectopic tissue. All right, guys. So keep that in mind. Just keep that in mind. The previous question, here you go. You guys can take, it's already recorded, okay? But you can take screenshots, it's fine. And it's already recorded. All right, let's see the next one.
53-year-old patient presents with bitemporal hemianopia. CT scan shows a stellar mass. Stellar mass. Involved structures originate from which of the following?
Don't read the options. Do you remember our previous session? I told you that in detail.
Yeah.
You remember?
Yeah,
So don't read the option. Tell me what's the answer.
So it can be two things, but optic tract is one of the scenarios, and there's another scenario. But I'm gonna look for optic tract, as I know that's one of the.
Why optic tract?
I remember it being really complicated. That sometimes you can get something knocked out from one way and another way, because it goes in and out and crosses over or something. I have to. I don't know this too well.
It was like, let me revise it again with you guys. It's about the origin of the pituitary gland, right? Bitemporal hemianopia, it means, yes, Muhammad, thank you so much. Either diencephalon, that is posterior pituitary, or Rathke's pouch, anterior pituitary. Rathke's pouch is from what? Is it endoderm, ectoderm, mesoderm, or what exactly? It's ectoderm. Okay, guys, so that's ectoderm. Here, sorry. Where is it? Yeah, here, ectoderm. As we discussed in the previous session, right? Okay, let's see the next one.
Okay, which of the following supplies the pelvic diaphragm? So this was a debated question because people said it could really be S3 or S4. And therefore there was some debate about which was the best answer. I'm not sure if it's S3.
S4 supplies the floor, right? S4 is the main nerve root.
S4, right, yeah.
Okay, let's see the next one.
A patient sustains an injury from a dusty nail on his left foot. Sorry, dirty or dusty. He received a full tetanus vaccination 7 years ago. Which of the following is the best course of action? So if he's had a full course within the last 10 years, I think nothing is needed.
Yes. Yeah, so according to the guidelines, I don't know, it's called Green Book or guideline or something, but everyone agrees on it anyway, that if you have had a full course of immunization, and the last dose was within 10 years ago, then you need nothing. Even if it's high tetanus prone wound, you need absolutely nothing. Okay? So simply nothing is needed. This question, you can see it in the website if you want to revise the guideline in detail about tetanus immunization. But know that if someone had full course within 10 years, nothing will be needed. Okay? And in some other cases, you will need single dose of tetanus toxoid. In some other cases, you need tetanus immunoglobulin and toxoid. But it's very unfun to talk about. You can find the guideline in the website. So don't worry, okay? Let's see the next one.
70-year-old female lady presented with an ulcerated lesion of the vulva, which of the following sites is likely to cause bilateral superficial inguinal lymph node metastases? This one is just a guess. I think I remember it being like B, maybe, but I can't remember why.
That's correct. It's labia minora. There is something, guys, a general rule in anatomy. That's a general rule. You can take it in any place. Any midline structure usually give bilateral lymphatic drainage. Anything in the midline, for example, tongue in midline gives bilateral, right? For example, anything that is midline will give bilateral metastasis. That's the general rule. When you go to the external genitalia in the females, labia majora is a lateral structure. Labia minora is a medial structure toward the midline. So, in your opinion, if there's a carcinoma in the labia minora versus carcinoma in the labia majora, which one gives bilateral metastasis? It is simple, right? Labia minora, it's in the midline. That's even in the Royal College of Obstetricians and Gynecologists guidelines. They tell you if a female presents with malignant ulcer at the labia minora, it's an indication for bilateral inguinofemoral lymphadenectomy. They already know that cancer will be on both sides. So it's indication on its own, you get me? It's that important. All right, guys. Let's have a break for 10 minutes. Let me tell you what will happen after the break. After the break, we'll take a few questions. Then I will guide you on how to access the mock. And then the mock itself is limited time, meaning that when the mock comes out, all of you need to log in at the same time. Okay? You have 100 questions, 100 minutes. It's all recent exams. And you, after the 100-minute finish, it will close on its own. It will give you your feedback, but it will close on its own, even if you didn't finish the exam. So I will tell you in detail how to access the mock right after the break. Okay, guys? So have a 10-minute coffee break. Then we have few questions. Then we go to mock. After mock, if anyone have specific questions, please write them down or try to remember them anyway so that we can do it in the open discussion after the mock. Okay? Any questions up to this point, guys? Great, perfect. Good job, guys. Okay, so see you in 10 minutes. Thank you very much.
Yeah, I can. That's okay.
That's great. Okay, please go ahead.
An elderly man develops a small ulcer over the lower lip. Histology shows pleomorphic cells with mitosis and keratin formation. What is the most likely diagnosis? Could go with squamous cell carcinoma. Lower
Yes.
lip and changes.
Yes, the changes and the location, it's goes together, right? Okay, let's see the next one.
A man works in a coal mine and inhales carbon dust. By which mechanism does the body primarily clear inhaled carbon particle? Carbon. Well, you do have the mucociliary escalator and the cough. Inhaled carbon particle. The escalator?
Okay,
The
do you
mucociliary
want?
escalator?
Okay, so do you kind of want to talk about how the? Yes, so mucociliary escalator is the main mechanism by which most particles deposited in the airways are cleared. Okay, that's like in general. But sometimes ultra small particles that reach the alveoli can be cleared by alveolar macrophages. So also in the question when you're looking at it, keep in mind about sometimes they can tell you in specific part of the respiratory tract what is the main mechanism of clearance, right? In the conducting airways mainly, we are talking about mucociliary escalator, and in the alveolar region and alveolar ducts and sacs is mainly the alveolar macrophages. Okay. Let's see the next one.
Which of the following drugs bind irreversibly to platelets? Aspirin, right?
Yeah, that's great. So aspirin binds irreversibly to platelets, right? Also clopidogrel binds irreversibly to platelets. That is correct. I don't know. Do you want to talk about antiplatelets? if you guys know, we can move to another topic, because I see them like asking a lot about their mechanisms of action.
I think
It's
we
up
should
to you.
move on because there are
Move
a
on.
lot of topics to cover, right?
Yeah, let's move on. Okay.
Which of the following structure is supplied by the axillary nerve? Shoulder joint capsule?
Okay. So many people report it in different ways, but let's just know what it supplies. Axillary nerve, it supplies upper lateral arm, right? It supplies teres minor, is that right? It supplies deltoid. Okay. And also it supplies sensory innervation to the shoulder joint capsule. So just know what it supplies. No matter what the question comes, you will be able to know. Khalid said lower lip, squamous cell carcinoma, upper lip, basal cell carcinoma is a good way to remember them for the first question. Not always true, but common is common. Yeah, okay. Also, I think if it is in, there are certain regions where there are poorer prognosis, squamous cell cancer. I think nose and ears, no, lips and ears, right? Have worse prognosis compared to other parts of the face. Okay. Anyway, let's keep going.
30-year-old is assaulted, sustained blunt trauma to the head in the emergency department. He's able to localize the pain to stimuli, opens his eyes in response to pain, and makes moaning sounds. His speech is incomprehensible. His heart rate is 80 beats per minute, blood pressure 130/80, respiratory rate 12 beats per minute. Which of the following is his Glasgow Coma score? Eye to pain, that's 2.
Okay.
Moaning sounds, that's also 2. I think he localized pain, right? Which
5.
gives it 4. No, 5. So 5
5,
and
5.
4, 9.
9. Yeah, C.
Okay, so we don't disagree about eye and motor command, but what about his vocal commands, or V score?
He says moaning sounds. His speech
And
is incomprehensible.
okay,
Seems like 2, right?
okay. So when we score about the Glasgow Coma score, when we give a score to each component, eye and motor and vocal, when we give score, we give based on what? Suppose, I will give you an example. Suppose you come to a patient, right? And right now, they do not open the eyes, not to pain, not to sound, not to anything. But then they open their eyes spontaneously. So if you want to score Glasgow Coma score, would you score it for the first observation or for the second observation?
Best observation, like the best score, right?
Yeah, so Glasgow Coma score, we score based on best observation. So even if the patient gives the variable responses, we will score them based on what best they can produce. Okay, so I think in my own opinion that the V, there are 2 different responses. Because first it sounds, then it became speech. Sound is different from speech. Speech is words. But I don't know, how do you score that then? That question is on debate for a very long time, by the way, not now.
You do make a very strong point.
So, Doctor, I seen earlier she said 11. Can you tell us why 11? The question, Dr. Muhammad, is that the problem, we don't have a problem with the eye and motor. We have a problem with the voice. So first they tell you moaning sounds. Okay, we know that sounds, there is only sounds, they score as 2. As 2. Then they tell us different story. His speech is incomprehensible. Meaning what? What's the meaning of that?
V3, right?
V3, inappropriate. So you can either answer it incomprehensible speech, you can either answer it as confused 4, or mowing sound, you can answer it as 2. So it can be either 9 or 11. The answer can be either 9 or 11. Is that right? So I think when they tell us word speech, it does mean, Dr. Laz, I think your camera is opened by mistake, maybe. Okay, yeah, so no problem. I think, in my opinion, it still means 11. I don't know, but it's highly debatable question, right? You tell me your opinion, guys. Just tell me your opinions. It's still, there's no confirmative answer, but tell me your own opinions on this question, because his speech is incomprehensible. That's, I'm sure it's in the exam. Many people told me it's there. So what do you think?
Maybe if you add a couple of moaning sounds, it turns into an incomprehensible speech. So it's still just moaning sounds.
Okay, so it's still 9 then. If you want to answer it based on that logic, you can give it a 9.
Would make sense.
Because if we revise Glasgow Coma score like the original one, they tell you speech, none is 1. 2 sounds or incomprehensible sounds as they write. 3 inappropriate words. 4 confused. 5 oriented. Is that right? Okay, so they said incomprehensible speech. Speech means that they talk words, that there are words. That's speech. It's not just sounds. It's a speech. Still, I think, in my opinion, if it comes to me in the exam, I will take the principles of scoring best possible observation. That principle, I will follow it and will answer it 11. But it's not confirmed. Still debatable question. This one came maybe when? 2 years ago, this question? Still debatable. Okay, let's move to the next one.
40-year-old male is involved in a fight. He sustains a stab injury to the a stab injury to the side of the face, causing a laceration of the parotid duct. Which branch of the facial nerve is most likely affected? It doesn't necessarily mean which part of the parotid, right? Buccal, maybe? Because it mentions the duct of the parotid gland.
Yep, that is correct. So the buccal branch of the facial nerve travels with the duct, right? So if duct is injured, most likely it is injured as well. Okay, let's see the next one.
45-year-old presents with a 6-centimeter laceration on his scalp. The wound is dirty and contaminated. What is the most appropriate management? Primary closure?
Yes, very excellent. We know scalp is very hypervascular. There's very huge amount of blood supply in the scalp, very good flow. So after thorough debridement and cleaning of any contaminants, we close scalp wounds primarily, even if they were originally contaminated, right? Scalp wounds have very high healing rates. As I told you, there's very good blood flow and vascularity there. So most of the times we do primary closure. We close them even if they are dirty or contaminated.
And when would we use rotational flap on scalp?
If there is a huge defect that you cannot bring it back without tension, then yes.
Okay. 52-year-old woman undergoes a radical cystectomy for the treatment of transitional cell carcinoma of the urinary bladder. A neobladder is formed from a segment of the detubularized ileum. Which of the following is the most likely electrolyte abnormality to occur? Hypokalemia?
Okay, let's talk about that. It is simple. So we know that urine shouldn't be flowing in the part of the small bowel, right? So we used here ileum, detupolarized ileum, to create a new bladder. We know that this particular type of ileal mucosa is not suited. It's not suited, right, for urine, to handle urine. So it will be irritated. It will be irritated. What happens is that ileal mucosa is also very good at something, which is absorption of bicarbonates. Okay? So what happens is that simply, this is the mucosa of the ileum itself. Okay? Urine comes along here and irritates the mucosa. This mucosa starts secreting. This is like excretory. So it starts secreting fluids. Now, these fluids are very, very rich in a lot of things. It has sodium, it has bicarbonate, it has potassium. So yes, I agree with you. Hyponatremia can happen. Hypokalemia can happen. Very nice. All that can happen. But most commonly, bicarbonate is lost in very large amounts. Okay? Bicarbonate is lost in very large amounts. When we have low bicarbonate level in our serum, what will happen? We know our serum exists in electroneutral state, meaning the positive charges in the serum absolutely have to equal the negative charges. Absolutely have to be equal to that, okay? So if we do like a small diagram here, this column represents the positive charges in the serum. This column represents the negative charges in the serum. Okay, most of our positive charges comes from sodium and potassium, among others like magnesium, etc. Most of our negative charges come from two things: bicarbonate and chloride, plus some other things like phosphates, sulfates, proteins, blah blah blah. Okay, so let's just say it is bicarbonate and chloride mainly. These are the two things that give most. When we start losing bicarbonate, like in this situation, chloride in the intracellular compartment leaves to the plasma to maintain electroneutrality. That is a law of physics. That has to happen. When bicarbonate reduce, chloride increase automatically. That occurs automatically in the plasma. Okay? So the usual most common manifestation in new bladders or even in urinary diversions is hyperchloremia because of this issue, loss of bicarbonate. Although the others can happen as well, like hypokalemia, hyponatremia can still happen, but hyperchloremia is the commonest. Okay, let's keep going.
5-year-old is brought to by his mother, complaining of hip pain. There's a history of cold a week ago. Which of the following is the most likely diagnosis? Transient synovitis.
Yep, we've been through that question in the past. It's simple. Let's move to the next one.
During gas exchange at the level of the peripheral tissues, which of the following changes occur in red blood cells? Gas exchange at the level of peripheral tissues. I honestly don't know this one, I think.
Okay, anyone want to give an answer to this thing? No answer? Okay, I'm going to tell you a story. Okay, are you ready to hear it? Maybe it's a new concept, but it is very common. Yes, Muhammad, very good. Muhammad answer is right. Okay, let me tell you here. You know, our cells, these are our cells, okay? I will not take much of your time, guys, but I will try to explain it simply. Those are tissues which have cells and things, right? Those are cells. Our cells produce huge amounts of carbon dioxide every day. Massive amount. You can never imagine it. It is so huge, which is just a product of aerobic metabolism. All of the time, the cells produce so much carbon dioxide. This amount of carbon dioxide, you know, if there's no mechanism to carry it, you will never be able to transport that amount to the lungs. It is so massive. You need a mechanism. You need a mechanism to transport carbon dioxide safely. Plus, remember, carbon dioxide, yes, it can dissolve in the plasma, but you cannot dissolve large amounts of bicarbonate, carbon dioxide, in the plasma. You need very high pressures to dissolve large amounts. So you need something else. You need something else. How that happens? Red blood cell come along. Red blood cell comes along. This is red blood cell. Carbon dioxide, the lovely thing about it, it is highly diffusible across membranes. It can easily move inside of the red blood cell. When it moves inside of the red blood cell combines it with water to form carbonic acid under the influence of carbonic anhydrase. We know that famous reaction, right? Then this carbonic acid breaks further into protons and bicarbonates. Now, if you notice something, the carbon atoms, right, and the oxygen atoms that were in the carbon dioxide are now here in the bicarbonate. Is that right? So essentially bicarbonate is carbon dioxide now. Now we have transformed carbon dioxide into bicarbonate. Now this process keeps going on. More carbon dioxide enters and more bicarbonates is produced. More and more is produced until the concentration becomes very high. So what will happen? Bicarbonate leave the cell in exchange for chloride to maintain electroneutrality. So at peripheral tissues, two things happen. Bicarbonates leave the red blood cells and chloride enters the red blood cell. That's why if you take a look at a red blood cell in the peripheral tissue, you will see it a little bit fat, gained some weight, a little bit swollen, because chloride enters along with it small amounts of water and red blood cells swell a little bit. That's in the peripheral tissues. Then now this same red blood cell with its bicarbonate and everything will go to the lung. Okay, that's alveolus on one side. And this is the red blood cell coming in through the blood vessels. I just want to add something just in case they tell you. This protons which is produced, okay, will be buffered by hemoglobin, okay? So hemoglobin here with its chains, right? It will bind to hemoglobin. But anyway, now, so we have outside bicarbonate, right? It was already outside. Now, in the lung, the process reversed. Bicarbonate enters the red blood cell, and the proton, which was associated with hemoglobin, dissociate and combines to form the same reaction, but in reverse, giving rise to carbon dioxide and water. Then what happens? When bicarbonate enters the red blood cell at the lung, chloride leaves, again to maintain electroneutrality. And this bicarbonate will just exit. This is called chloride shift. This principle is called chloride shift. That at the peripheral tissues, right, bicarbonate formed inside of the red blood cell leave and chloride enters. And in the lung, the process reverses. It's called chloride shift or hamburger phenomenon. This process is responsible for the transport of up to 70% of the entire bicarbonate, carbon dioxide produced in the body. So this is the main mechanism of carbon dioxide transport. No problem. Is it clear to everyone? So it means let's go back to the question, okay? Now you guys tell me, at peripheral tissue, what happens? We said what happens? Chloride enters bicarbonate leaves, right? So option B, bicarbonate leaf, red blood cell into the plasma. So it's simple. Okay, let's move to the next. Before we move, is it clear to everyone this concept, chloride shifts? No questions, right? Good, let's see the next one.
45-year-old woman presents to her GP with a history of enlarging crusted weeping area affecting one nipple extending into the areola. In addition to mammography, which of the following is the most appropriate investigation to confirm the clinical diagnosis? Punch biopsy?
Yeah, Paget disease, punch biopsy. We've already been through that, so simple. Let's move.
Which of the following muscle is responsible for vocal cord abduction? Vocal cord abduction? I think I forgot this. I'm just gonna go on a limb. Either A or C.
So it is posterior cricoarachnoid, right? The only muscle that abducts the vocal cords and open the rhima glottis is the posterior cricoarachnoid, right? Again, we've already been through that in previous sessions, so simple, right? Okay, posterior cricoarachnoid. Remember, that can be in a different question. They can tell you like, someone have been through total thyroidectomy post-operatively, there is upper airway obstruction, patient is choking or that is a stridor or whatever. So which muscle is paralyzed or which muscle is affected? Again, it's posterior cricoarachnoid, right? Okay, let's see the next one.
A 30-year-old man presents after stepping on a rusty nail. Which of the following infecting organism is most appropriate to consider in this type of injury? Clostridium tetani. Okay?
Tetany, right?
Yes.
Okay.
A 6-year-old child is admitted for observation. Below which urine output value should you worry? In a pediatric, maybe I think 1 ml per kg per hour.
Yes, that's true. So in adults, less than 0.5, in pediatrics, less than 1, in infants, less than 2. Okay, let's see the next one.
Which of the following coagulation factors is affected by warfarin? 9. C.
9, right? Right? 10, 9, 7, 2, so 9.
A 30-year-old man presents to the emergency department feeling unwell. An ECG is performed, shows absent P wave and a widened QRS. Which of the following electrolyte abnormalities is the most likely cause? C?
Yes, very good. Hyperkalemia, right?
Yeah.
Okay, widened QRS, then sine waves, then... Okay, loss of P wave, tall tinted T wave, then widening of the QRS, then fusion of QRS and T wave, then sine wave. Right, okay.
A 31-year-old sustains traumatic bilateral lower limb amputation after falling in front of a train. He was brought to the emergency department shocked and comatomed. He was intubated and bilateral lower limb tourniquets are applied in the pre-hospital setting. What is the best course of action? Probably initially you would go with B, but since the trauma is just so intense, you could just go straight for the O negative blood, right?
Yes, yeah. So, like in Bailey, right? Replace like with like. If someone is bleeding, give them blood. If someone is vomiting or something, give them crystalloid. So replace what is lost with a similar fluid. So that reminded me of a case that we worked on maybe like several years back. She was a woman who came in after a road traffic accident, and she was unstable on arrival, very unstable. That is, she was hypotensive and tachycardic and unconscious. So in tandem with the guideline, we went with damage control surgery. That is, we gave her fluids and everything. And then inside of the operation, there was a laparotomy, and there was massive intra-abdominal multiple, like spleen was injured, there was a splenectomy done, the liver was bleeding, there was multiple bowel loops lacerated. It was a very complicated thing. And then after the surgery, for some reason, she developed generalized peritonitis. And then I think it was a leak in one of the bowel loops. Then after the operation, we had, for some reason also, the second operation, I was not in it, but for some reason, the umbilicus was damaged and was removed during the operation, the umbilicus itself. So the wound was closed and there was no umbilicus. She recovered very well, this woman, and everything was fine. But later she sued the hospital. So we didn't understand why she would sue the hospital. We did a very good job with her and everything. She sued us for her umbilicus. Really, that's a true story, by the way. She said, "Where's my umbilicus?" And she sued the hospital for, oh my God, there was a stupendous amount of money. So moral of the story, don't forget patient's umbilicus. That's if you don't want the hospital to close. Okay, so we understand there's blood, right? We give this patient blood. Don't forget the patient's legs, okay? Come back to the train station and get their legs or you'll be sued. Should we initially go with fluids? If no response, we activate hemorrhage protocol. Okay, yeah, I agree with you, okay? But the best course of action, if you normal saline is not the best actually here, especially in the shocked patient, when you give them a lot of chloride load in a normal saline, it's not the best. If it was like warm drinker lactate, maybe we consider it. But when you give patient a lot of normal saline in a shocked patient, you add to the metabolic acidosis. So it's definitely not the best course. Best course is to give blood, right? Okay, let's move.
70-year-old bedridden patient develops a sacral pressure ulcer measuring 2 centimeters in diameter. The wound is superficial with no necrosis or signs of infection. What is the most appropriate initial management? Bedridden with a sacral ulcer. Superficial, no necrosis, signs of infection. Non-adhesive dressing?
Very excellent. Very nice. So, bit sore management, right? It is, look, treat it like a wound. Treat it like a wound. If there's necrotic tissue, debride, right? If there is collection or pus, drain. If there's a lot of exudate, use alginated dressing or caltostat. So you treat it like a wound. Also, if there's excessive exudate, you can use VAC device, vacuum-assisted closure. But according to NICE guidelines, they tell you do not routinely recommend it unless there is excessive exudate and the wound is large and deep. Okay? Stage 3 and 4, presacral arthrosis, usually we go for after the wound is fresh and granulating and there's no signs of infection. We can go for flap, gluteal flaps. Okay? But never use dry dressing. What's the difference between A and C? Big difference, big difference. Non-adhesive dressing doesn't stick to the wound. And when there's exudate, it has a pad which absorbs it. But when you actually remove it, the dressing just falls. You don't have any force. But dry dressing like goes, it sticks to the wound. And when you want to change the wound, when you remove that dressing, it's stuck to the wound. So you cause secondary injury to the wound and disrupt the granulating base and retard healing. So definitely not advised dry dressing like goes, not advised at all, right? So if they tell you necrotic tissue, debride. If they tell you excessive exudate, go ahead for caltostat, usually the correct answer, which is alginate. If they tell you stage 3 and 4, and after the wound is prepped, go for flap, okay? That's the summary of the situation.
Which of the following changes occurs as a consequence of ADH action?
Okay.
Probably decreases urine output if it's there.
So they told you here, A, decreased total body water, increased urine output, decreased extracellular fluid, increased intracellular fluid, decreased interstitial fluid. No, this option not there.
Probably D.
Very excellent. Increased intracellular fluid, right? We know that. It's ADH goes to the distal nephron, specifically late part of DCT and collecting duct, and insert aquapore in 2 channels. That enhances the absorption of free water. Everyone knows that, right? Everyone knows that. Not everyone knows that it also increases urea reabsorption from the ascending limb of Henle's loop and increase the medullary tonicity, thereby increasing the concentration gradient for water reabsorption. That's an additional mechanism of action that everybody tend to forget. So not only it increases permeability, but it increases the concentration gradient for it. Okay, so we have this water, right? That's distal part of nephron. Water went out and reabsorbed directly to a blood vessel. So initially, the intravascular compartment is increased because water is directly added there. But remember, it's a free water. So it will dilute sodium here and reduce the tonicity. So this water, which was added because of reduced tonicity, will go where? Cells, right, which have more tonicity. So in the end, it increases intracellular compartment. Okay? So simple, right? Okay, guys, let's see the next one. Why not C? It will not decrease the extracellular fluid. It will initially increase it, then it will reduce it, right, doctor? It will not decrease it at all. Okay.
58-year-old with a history of Hashimoto's thyroiditis presents with vomiting, confusion, and drowsiness following surgery. What is the most likely diagnosis? A?
Yes, so Hashimoto means she's hypothyroid. And then she had surgical stress, right? So myxedema coma, also a simple question. Okay, let's see the last one.
45-year-old patient presents with pruritus, pale stool, right upper quadrant pain, and dark urine. Which of the following biochemical finding is most likely? You do have increase in conjugated bilirubin, that's for sure.
Okay.
Increased urinary urobilinogen.
How is that?
Although
That's
that is
obstructive.
also seen with unconjugated hyperbilirubinemia. Decreased urinary conjugated, increased urinary unconjugated. I'm gonna go with B.
Think simple. Think simple. Tell me that, okay, there is obstructive jaundice.
True.
Is that right? Okay,
Yes.
obstructive. So bile doesn't go to bowel. So, is that right? It doesn't go to bile, obstructive jaundice. You agree?
Yes. True.
Okay. So it means bacteria in the bowel does not convert that to urobilin. So we know that it will not
True.
increase. Okay.
So A?
Yes, A, right?
I get you.
That is, it will decrease. It will decrease or even undetectable.
So you don't have the conversion of bile in the bowel, which turns into stercobilin and the urobilinogen that gets reabsorbed back and then excreted, right?
Yep, that's correct. Yep.
But you do have urinary conjugated bilirubin, right?
Yes, yeah, conjugated bilirubin itself will be in the urine.
But not urobilinogen.
No. Okay, let me explain. Let me explain here. Okay. And revise in the same time. Okay, let's explain and revise in this. That's our liver. Okay. Liver should receive unconjugated bilirubin, right? Unconjugated bilirubin. We just write UB here. Liver should receive that. But remember, unconjugated bilirubin is not water soluble, meaning kidney cannot filter it into urine. So even if it increases in urine, urine will not have unconjugated bilirubin because it's simply not water soluble. But liver takes it, conjugate it with glucuronides, and now we have conjugated bilirubin. Now, conjugated bilirubin is water soluble, okay? It can be filtered in the urine. Then that is basically, right, excreted with bile into the small bowel. Okay, what happens to this conjugated bilirubin? There is a bacterial enzyme called deconjugase, which will convert the conjugated bilirubin back to the usual unconjugated bilirubin. That's first step. Then the next step, further bacterial enzymatic action on it will convert it to urobilinogen. Urobilinogen is a colorless substance. Okay, colorless substance. Most of it will be excreted in stool, and now we call it stercobilinogen. Stercobilinogen. When it sits and oxidizes in the air, it becomes stercobilin, which is colorful. That's what gives stool its color. Okay. The majority of urobilinogen goes like this. A small amount of urobilinogen is reabsorbed. Okay. So we have reabsorbed back to blood now, okay? Portal blood. Some of that reabsorbed amount is taken back by the liver and excreted again in intestine. This is called enterohepatic recirculation of urobilinogen. But a very tiny amount escapes into the systemic circulation and actually appears in urine and oxidizes outside into urobilin. And that's what gives urine its color. That's normal. Do you agree, guys? No question on that? No question. Okay. Now we have Dr. Ryan, your mic, if it's possible. Can you mute? Dr. Ryan. Okay. Maybe her kids, but I will mute manually. Okay. Okay, so we agreed about the normal. Is that right, guys? So now let's talk about obstructive jaundice. Obstructive jaundice, the issue is here, right? Conjugated bilirubin cannot reach the intestine and it flushes back to the circulation. I've already told you it's water soluble, so it appears in kidney, right? So there's increased conjugated bilirubinuria. That is the bilirubin itself. شخصيا يعني bilirubin without being changed. Okay. Then it means also that the conjugated bilirubin does not reach bowel. So urobilinogen is not formed, not reabsorbed, not appearing in the urine. So there is increased conjugated bilirubinuria, and reduced urobilinogen in urine. Do you agree? So out of these options, we need to look for either this or this. Let's see. The increase in conjugated bilirubin is not in options. Not in options. But reduced urinary urobilinogen is in options. So it is option A, the answer. Claro? No problem? Good. Okay. So now it's enough for today, but we will do the mock, and then after the mock, we will have open discussion.